Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning. Welcome for the second day of Grappa. And we have lots of upcoming interesting experience and local case discussion to be shared. Once again, I would like to thank Novartis for inviting all of us. I'd like to thank my colleagues in rheumatology also for always a pleasure and honor to be with them and seeing them again physically. I'd like also to welcome those who are attending with us online. I hope next time that we can see you, all of you physically. I'm happy to tell you that Dubai is almost back to normal as the pre-COVID area. And the city is ready to welcome all over the world for the expo. So I would like to invite all of you to come here to Dubai as we, of course, attended our meetings in the past pre-COVID area. All of us were looking forward for our past days. Today we'll have, as I mentioned earlier, going to start with local cases discussion from both dermatological perspectives and rheumatological perspectives as well. We see on our daily practice cases, difficult cases to treat, whether difficult areas to treat, or cases with comorbidities. So I'm not going to take much of time. I would like to thank my colleague, Dr. Zayat, the rheumatologist, who's I'm going to hand over the mic to start with the first case with Dr. Gaita. So thank you, Dr. Zayat, also being with us here. Thank you. The mic.
Thanks, Dr. Hamadi. I'm really excited again to be in Grappa here. This is another step in this combined journey between us dermatologists and rheumatologists. And it seems we are meeting again and again in different meetings that tells us how in common we are and how common practices and disease that we share. Probably you've seen the very exciting program, and as usual, we're starting with local cases. And you would see different interesting local cases, starting with one of our best stars in rheumatology, Dr. Geeta Harifi, who's a board-certified rheumatologist and fellow of at the University de Strasbourg, and her areas of expertise, including probably all rheumatology conditions, but not the least rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. Dr. Harifi is also an expert in musculoskeletal ultrasound and has been leading many teaching programs in this area in the region. So welcome, Dr. Harifi.
Thank you very much, Dr. Zayat, for this very nice introduction. It gives me a great pleasure to take part in this Grappa standalone meeting, and I would like to thank Novartis for inviting me to present a case about the management of PSA with comorbidities. And I would like to focus in this case on the eye and the central nervous system. Can help me to go to the next slide, please. It's okay. So here are my disclosures. So let's start with this first case of a female patient who was a 43-year-old of age from Iran. She was holding the stressful position of an HR manager in one of the hospitals in the UAE. This patient has been diagnosed with MS 6 years back, and she was on interferon injection ever since. She had a history of psoriasis. She has psoriasis at the time of diagnosis, and she reports MSK, musculoskeletal complaints that have started in her 20s, but it took her till the age of 30 to be diagnosed with psoriatic arthritis back in Iran. She's been on NSAIDs for years, sometimes on daily basis, and sometimes with, overdosing, NSAIDs. When I asked her if she has been on DMARDs, she said that methotrexate has been tried, but she couldn't tolerate it. And sulfasalazine was started for up to 3 or 4 months, but she had to stop it because she didn't have any benefit. The patient was HLA-B27 positive and had history of recurrent uveitis. One of the episodes was bilateral, and she had in total 4 episodes. The last one dates back in 2016. She presented to me for the first time last April 2021 with a severe bilateral knee and ankle pain, severe inflammatory low back pain with a significant morning stiffness, more than 3 hours sometimes. And she reported she was really fatigued. She reported a significant fatigue that was interfering with her daily responsibilities. The patient described herself as a alkoxia addict. She was on alkoxia for the last 2 years on daily basis. And when I checked her BP initially, it was 170/80. So we referred her quickly to the cardiology for Holter BP and a hypertension assessment, and she was started on amlodipine. Now, initial assessment showed sacroiliac joint tenderness in more than 3 maneuvers. There was a significant thoracolumbar stiffness, and she had bilateral Achilles tendon tenderness, the insertion, with a bilateral knee tenderness without swelling, without evidence of effusion. She had nail psoriasis, a mild nail psoriasis with mainly pitting changes. And she had scalp psoriasis. She wasn't really bothered by her nail psoriasis, but her scalp psoriasis was kind of an issue for her. The skin lesions were limited to the elbows. So an overall, I would say, mild psoriasis, skin psoriasis. Now, if we want to assess the disease activity at this stage, we could tell that there were 4 tender joints. And it's actually the antisial points were tender and not the joints. So 4 tender antisial points, no swollen joints. Pain, the pain was significant, and the patient had raised inflammatory markers with the CRP around 10 at many occasions. The skin disease was rather mild, with the body surface around 3%. Now, obviously, the disease was active, MDA was not achieved, and we can tell that in this specific case, beside the peripheral manifestations, the axial involvement was significant with a BASDAI above 5. Now, so obviously we requested an MRI. The patient has been diagnosed back in the time in Iran, and we didn't have any documents. So I requested an MRI for both diagnostic and disease activity assessment purposes. And as you can see here on the MRI, I hope you can see, the light is probably too, can reduce the light, but this is a stir sequence of the SI joints, basically to show a sacroiliitis. Sacroiliitis is defined for the dermatologist, is defined a significant bone marrow edema on stir sequences. And basically what you can see here is that there is a little bit of hypersignal around the both SI joints, but this is rather mild. And this is not the kind of bone marrow edema that you would expect with such an active disease. You could argue that there is a bit of a, fatty metaplasia, but as you know, fatty metaplasia, you need, you see it right on T1 sequences, but you can tell that when you suppress the fat, this area looked in hyposignal because there was some fatty degeneration. So the SI joints MRI was not that helpful. We were lucky enough in this case to be able to do an MRI of the thoracic spine. Since the MRI of SI joints was not that helpful. And as you can see here on stir sequences of the thoracic spine, there were signs of activity in the form of this active Romanus spondylitis. What is active Romanus spondylitis? We have dermatologists with that today. I'm trying also to make it simple for them. So you can see that these hyper signals in the corners, in the anterior corner, that show that, on the stir sequences, suggestive of active spondylitis. And you can see this on many vertebral corners here. So we call this active Romanus spondylitis, and they're indicative of an active disease. So this is a case where even if the MRI sacroiliac joints didn't show significant changes or significant bone marrow edema, the MRI of the spine was very suggestive of an active disease. Now, this was for the axial manifestation. The patient had also peripheral complaints, and when I scanned her Achilles tendon, you can see here some significant changes. So to start with, you have the Achilles tendon that looks rather swollen at the insertion with a hypoechoic aspect near the insertion. The fibers not as obvious at near the insertion, but you're probably more attracted by these structural changes on the bone. So you have here multiple erosions in the form of bone discontinuities with a step-up change here in favor of an amphizophyte. And this is actually typical for psoriatic arthritis. This combination of erosive and new bone formation is very suggestive of psoriatic arthritis. There was no power Doppler in this case, but obviously this image fulfills the criteria of enthesitis according to the Amarak definition. So what we've done in this case, the first thing I did is that I stopped NSAIDs. That wasn't, kind of an urgent thing to do in this patient with obviously an iatrogenic hypertension. And I started her on secukinumab at the dose of 300 milligrams subcutaneously without a loading dose. And I saw the patient 2 weeks back, 5 months later from starting secukinumab. And the patient was absolutely pain-free. Hormonal stiffness has drastically reduced, and she had no peripheral complaint. Her blood pressure is back to normal. She even stopped amlodipine without telling her cardiologist, but she did. And her, BP readings were still good. The BASDAI was 2, and the minimal disease activity score was achieved. No, her scalp psoriasis has subsided. Nail changes are still there. They've improved, but didn't totally disappear. And more importantly, this patient didn't have any flare-up of her uveitis and didn't show any worsening of her multiple sclerosis manifestations. So why an anti-IL-17 in this case? Well, in the presence of uveitis, what comes to our mind, at the first place is anti-TNF, obviously. Yeah. The fact also that in this patient, the psoriasis, the skin psoriasis was rather mild, would have been actually a reason to at least not prefer IL-17 inhibitors, because we tend to prefer IL-17 inhibitors when psoriasis is more active or severe. But the truth is, the presence of multiple sclerosis here was, a no-brainer, and the IL-17 inhibitor was the molecule to choose. I would say also that the fact that the peripheral disease of this patient, and probably the axial disease as well, was rather enthesial, more enthesial than synovial, is also a reason to me to prefer IL-17 inhibitors, not because anti-TNF inhibitors or anti-TNFs do not work on enthesis and enthesitis, but because the data, or at least the indirect comparison of the data between anti-TNF and IL inhibitors shows a slight superiority of anti-IL-17 inhibitors in the enthesial disease. And also the fact that there was no active uveitis for the last 5 years was rather reassuring in this case for the choice of anti-IL-17. Now, let's go for the focus. Let's do a focus on MS and its relationship with the PSA and the choice of anti-IL-17. And here is some evidence on IL-17 in the demyelinating disease. So first of all, data has shown that 1.5% of all spondyloarthropathy patients suffered from multiple sclerosis. This is considered as coincidence, but the association is there and we should be aware of it. Now, TNF inhibitors, due to their non-selectivity, could increase disease activity in MS and therefore are contraindicated. We've seen also cases of CNS demyelinating conditions that have started after starting anti-TNF, especially with infliximab. And I personally had 3 cases of demyelinating optic neuritis under adalimumab. So the anti-TNF effect is rather negative in this condition. Now, IL-17, many studies have shown the role of IL-17 in multiple sclerosis, and all have concluded that IL-17 expression is associated to MS development and progression. Indeed, we have a proof of concept study that targeting the IL-17 can be not only safe, but can be only beneficial in multiple sclerosis. And I would like to present this interesting study to you. This is a study published in 2016. It was a randomized proof of concept study of the use of IL-17 on brain lesions in relapsing remittent multiple sclerosis. And so the patients, above 70, individuals were randomized to receive either placebo or secukinumab. The secukinumab was given IV in this trial. And those patients were followed for with the MRI scans within 30 days prior to randomization and on a monthly basis during the treatment period and at study completion. And the primary endpoint here was the cumulative lesions on MRI, on brain MRI scans from week 4 to week 24. And what this study shows is that compared to placebo, secukinumab has been able, secukinumab is here with the full dots line. You can see that it has reduced the mean number of cumulative MRI brain lesions in those patients with MS throughout the treatment period. This was not statistically significant, but interestingly, when we looked at the new gadolinium enhancing T1 lesions, the secukinumab was able to reduce those lesions, those new lesions, so disease progression, by 67%, and this was statistically significant. So this study, although limited by the small sample and the short duration of the study, provides a proof of concept of the use of IL-17 as a potential target in multiple sclerosis. Some other case reports have also shown the efficacy of secukinumab in patients with concomitant multiple sclerosis and spondyloarthropathy, with stability of the brain lesions and sometimes even remission of the neurological symptoms on IL-17 inhibitor. Now, the other issue in this case was the uveitis. Uveitis should be looked at as not as a comorbidity, but as an associated disease, I would say. But uveitis in psoriatic arthritis is not uncommon. The prevalence is around 7 to 20% according to the studies. It has some particularities because the phenotype is slightly different than AS. Uveitis in psoriatic arthritis tends to have an insidious onset, tends to be rather anterior and intermediate and not only anterior, and sometimes bilateral. And this is an important message for our colleague dermatologists. It's frequently regarded as an early indicator of PSA in psoriasis patients. So when your psoriasis patients develop uveitis, you know that the risk of developing psoriatic arthritis becomes significant, and the odds ratio is like 31. Now, let's look at the role of IL-17 and TNF pathway in the pathophysiology of uveitis. In humans, the presence of IL-17 and TNF-alpha has been shown to be increased in aqueous humor in patients with spondylarthropathies. In patients with uveitis, interestingly, the TNF-alpha was rather low, and they had high levels of IL-17, which probably indicates a different role of the two cytokines in uveitis and probably at different stages of the disease. Animal studies have demonstrated the efficacy of antibodies blocking IL-17 and TNF inhibitors to reduce intensity of uveitis, highlighting their therapeutic role. Now, obviously, monoclonal antibodies targeting TNF have, in particular, adalimumab or infliximab, are used to prevent new relapses of uveitis and to sometimes treat uveitis. This is an established role, but let me just remind you that in PSA, and for those who attended the Prof. Laura Coates' talk yesterday, it's still, the recommendation is a conditional recommendation because we're still lacking studies or trials in this particular indication, which is uveitis plus PSA. Uveitis may occur while receiving those treatments, though. This is called paradoxical effect, and this has been shown in patients who had no history of uveitis but developed uveitis under anti-TNF. We don't fully understand the pathophysiological, mechanisms of this phenomenon, but this is rather, known. Now, in contrast, the etanercept is more frequently associated with emergence of new uveitis than monoclonal, and etanercept is avoided when patients has active uveitis. A recent analysis of patients included the phase 3 clinical trials of secukinumab revealed the low incidence of 1.4 per 100 patients year. When we look at the secukinumab program, altogether, psoriasis, PSA, and AS program, the incidence of uveitis was rather low. It's obviously slightly higher in the AS program because uveitis is more frequent in that group of patients. The exposure adjusted incidence in the PSA program was 0.12, regardless of the dose of secukinumab used. And when you know that the incidence rate of uveitis in PSA population is somewhere around 0.5, so this is rather a low incidence. Now, without going into the pathophysiological details, but the role of IL-17 in the uveitis has been studied extensively, and we know that the levels of IL-17 are high in the serum and in the aqueous humor of patients with uveitis, with autoimmune uveitis. So targeting IL-17 seems like a reasonable approach. Now, animal models of spondyloarthritis demonstrated that IL-17 blockade reduced intra-articular inflammation. For secukinumab, there was a very small study that has shown some encouraging results, and subsequently 3 randomized controlled studies, including SHIELD, the trial called SHIELD evaluating subcutaneous secukinumab, failed to demonstrate any advantage regardless of patient's phenotype. Now, more recently, a new study with a small sample of 37 patients suggested that when we use secukinumab as IV, at the dose of 10 milligram per kg every 2 weeks, we had better results on eye inflammation. So subcutaneous bioavailability may be the problem and may be partly the cause of secukinumab treatment failure in the randomized studies. And this would probably mean that there is still an opportunity for phase 3 clinical trials with IL-17 inhibitors in uveitis. So it's a to be continued story. But I had to show you this study before the end of this talk. This is an animal study on mice that has shown that blockade of IL-17 is interesting in uveitis, anterior and posterior uveitis, because as you can see here, it drastically reduces the amount of cells by section. So the cells trafficking in the anterior chamber or in posterior chamber. So it's beneficial for uveitis, and this study is very has shown actually numbers are very striking. However, this study has brought to the surface an anticipated side effect, which is structural changes in the retina. So in this animal model, it has been shown that there was some photoreceptor toxicity with IL-17. This was totally unanticipated, and this needs further studies and clarification. So to summarize the data for this case, if we do a comparison of the efficacy of TNF inhibitor and IL-17 in both uveitis and multiple sclerosis, in uveitis, anti-TNFs have a label, and they're absolutely beneficial. With IL-17, we're still lacking some data. There is some promising and encouraging results, but we could say that it's inconclusive at this stage. In multiple sclerosis, anti-TNF are definitely contraindicated, while anti-IL-17 is totally safe in MS, but could have also a beneficial effect. So with this, I would like to thank you for your attention, and I'm happy to take any question.
Thank you very much, Dr. Greta. We'll take I would like to remind you that if you have any question, please don't hesitate to write it. You can send it over, and we'll answer all your questions at the end of the talks. We'll move forward with the next speech or next talk with Dr. Fatma Shaban. Dr. Fatma Shaban, a senior consultant dermatologist at Sharjah University. She has published in the field of psoriasis and atopic dermatitis. Would like to welcome you, Dr. Fatma Shaban, and thank you for being with us on the second day. Thank you.
Thank you, Dr. Anwar. Good morning, everybody. Good morning thank you for attendance, and thank you for Novartis team for giving me this great opportunity. Regarding my experience with secukinumab in psoriasis, 1 second, I am in a mess now. Okay. Regarding psoriasis disease and its comorbidity, today we are talking about arthritis. Apart from arthritis, what about a psoriatic patient if he's having arthritis? What are the other comorbidity which he or she is going to develop? Actually, there are many, and the most important of them is depression. It's around 1/4 of the patients, 25%. For IBD, it's only 1%. And for obesity, it's about 18%. And for hypertension, it's 36%. Ischemic heart disease is 13%. In my experience, depression is the worst. And I'm going to show you a case in my experience with that depression and how it led the patient even to suicidal attempts. Depression, if the patient is not treated, 20% of them might commit suicide. And if they are treated, 10% might commit suicide. As for IBD, it's also very important to put it into consideration. And we have to know that 1% only from psoriatic patients develop IBD, but around about 4 to 12% in different studies showed that IBD patients might develop psoriasis with all its comorbidities. Okay. My first case is a 37 years old, beautiful female. Since 10 years, started psoriasis in United Arab Emirates, and she had PASI 12. It's not that much, but what's the worst? It's the quality of life. DLQ 30, because she committed suicide once. And she was with me since etanercept. She had a psychological trauma from anti-TNFs, and me too. I had a psychological trauma. I started biologics since 17 years, started with the anti-TNFs. We had ups and downs, adding methotrexate, and the patient gets again recurrence of the case, and we increase the dose of methotrexate with all its contraindications and all its side effects. So I heard about a new molecule called secukinumab, interleukin-17 inhibitor, and still I was not feeling that trusting that this molecule would not be that different from the others. But it was a miracle from my side and for the patient too, because the patient reached to switch it from etanercept to adalimumab. And for 2 years, she started to take methotrexate with all its problems. So I told her that I will give you secukinumab. And she said, I know, it's the biologic, and again, you will give me the methotrexate and so on, so on. So I tried to soothe her because she was my first patient on secukinumab. And I will show you now the pictures. She had a problem with her kids and her husband. Her husband was to threaten her that he's going to divorce her because she is always having very low mood. And she had suicidal thoughts. And her kids refused to eat from her hands. Oh, sorry. It should have been switched or turned, okay? The kids refused to eat from her hands. Imagine how she feels. Even the face was affected, the scalp was affected. The legs, the feet. And after 2 weeks, she started to have very much improvement. This is not important. For me, it's not important. Why? I will tell you why. After 6 weeks, completely clean. She is having secukinumab since she's approaching 6 years. She's not with me now, but she used to call me. She used to be very appreciative because I gave her this molecule. It was the first time for me to have a drug with sustainability because I used to suffer from the methotrexate with the anti-TNFs. Completely clean till now. She's not with me now. She's in another place in Al-Ain, as I think that she's in Abu Dhabi or Al-Ain, and she is receiving the same drug, the secukinumab. Okay, this case, I consider it my best case because she's still with me since approaching 6 years. She is 67 years old female with history of psoriasis since adolescence. She received multiple, as usual, methotrexate, cyclosporin, adalimumab, and methotrexate, and so on, so on, so. PASI was 23, and DLQI is 27, BSA is 15. Body surface area involvement. Sorry because it's not turned it off properly. She had thick plaques, okay? And all of them were erythematous with thick scales. And after 1 month, by the way, this is not psoriasis. This is post-inflammatory hyperpigmentation. She is clean. Since that time, after 1 month till now, she is completely clean. And I would like to tell you something very important that she was with me last week. And I asked her, why didn't you come since 2 months? She said that she had corona. What's interesting about this is that she had corona and she had the treatment and she is okay now. And she's still having no recurrence for 1 single lesion even of psoriasis. Now I was blaming myself. Why didn't I take another photo? Because she's as it is. Since the first month, she is as it is. No change, complete clean skin. I consider her the best case for me because she's still with me. This is the back area. And as we remember, the psoriatic arthritis, according to the Grappa, is usually accompanied with the peripheral arthritis, dactylitis, axial disease. as well as skin disorders and nail psoriasis. The other case is for the other comorbidities of psoriasis. The first one with depression. The second one, she had no comorbidities except that she doesn't like herself. But she didn't have hypertension or anything else. But this one is having hypertension and also sugar. And she is very old. She is 82 years old. And she is having no history of psoriasis and no family history of psoriasis and no drug which might precipitate psoriasis like lithium, like beta blockers, like whatever. So I was confused. How psoriasis in this age all of a sudden? So I started to take a biopsy from the lesions. It was all over the body. And here is as you can see here, there are subcorneal pustules, and there is papillomatosis, and there is perivascular lymphocytic infiltration. And this is the subcorneal pustule in the right side. So this is a case of psoriasis. So it was my around 5th case with secukinumab, and I gave her secukinumab. And after 4 weeks, as you can see here, the difference. Sorry, because this one should have been, the one on the left side is on the right side would have been, it should have been broadened, but she was completely clean after 1 month. She's not now with me because she was with her son when she came to me in Sharjah, but after that she shifted, and I don't know what is she doing now. I think now she's approaching 90 years old. Okay, I would like to remind you of something very important, something called the leaky gut. It was proved that all these patients, psoriasis, even acne, especially acne conglobata, eczema, atopic eczema, IBD, arthritis, rheumatoid arthritis, depression, sinusitis, all these diseases, they have pro-inflammatory markers in their blood. If you are a dermatologist and you check the CBC for a patient with acne, you will find that this patient is having increase in the mean platelet volume, increase in the platelet lymphocytic ratio, increase in the platelet neutrophilic ratio. All these are available also in psoriasis and also in cancer. These patients having something in common. It's called the leaky gut syndrome, or the super antigens which are released from the gut and leads to aggravation of inflammation in these tissues. One important thing about secukinumab, I knew it lately, that after 12 weeks of studying secukinumab, the blood parameters regarding the HDL, low density lipoprotein, very low density lipoprotein, triglycerides, and cholesterol, high density cholesterol, all these are reduced, except of course the high density. The high density, the better. But all these were reduced. After 12 weeks, this means that it has a very good efficacy on the serum parameters which are leading to the comorbidities which are available with psoriasis. There is another important thing, the plaques, the atherosclerotic plaques. In the burden of atherosclerotic plaques in these patients due to atherosclerosis and hypercholesteremia. A study was done, and it was proved that in comparison to anti-TNFs and ustekinumab, as you can see here, in ustekinumab, the atherosclerotic plaques after treatment is the same like before, while with anti-TNFs, there is a reduction in these burdens of these plaques. But here the reduction is more. And this graph will show you more. The grayish one is for secukinumab, and the others, which are less, are for the others. Which shows for us that it's not only for the psoriasis, but for also the comorbidities. Thank you.
Thank you very much, Dr. Fatma. Dr. Fatma is a dear colleague of mine in UHS. That was very exciting few cases and shows us how successful as you are always. I'd like to introduce our next very famous rheumatologist who's been practicing rheumatology for the last 20 years or more, and he's experienced in nearly every aspect of rheumatology. Please welcome Dr. Atira Ansari, who's a consultant rheumatologist in Mediclinic Airport Road Hospital in Abu Dhabi and former vice president of the Emirates Society for Rheumatology, who's going to speak about difficult to treat cases in psoriatic arthritis. Thank you very much.
Good morning, everyone. Thanks, Dr. Ahmed, for presentation. They give me the job of presenting a difficult case in terms of concepts and how we manage them. The difficulty here is about the concepts, not about the scoring system as we have now. This guy is a Syrian guy. He's well educated in, I'm allowed to do that now. Well-educated gentleman. He's known to have psoriatic arthritis. He presented always with a back pain seen as inflammatory back pain, history of psoriasis, extensors mainly, peripheral joints, mainly his feet, plantars, Achilles, ankle tendinitis also. He was managed by my predecessor. Some people know him. He went to Canada now. And clearly from the case notes, he was started with the methotrexate first, as classically we used to do at that time in 2009. And he had a partial response. He was commenced on Enbrel. And because he had like Enbrel, Humira, Enbrel, because of no improvement in the skin, he switched to Humira. What happened reciprocally is that the skin gets better, the joint, the pains are back because he tends to respond to Enbrel. So he put him back on Enbrel with methotrexate. He has good response for pain, but keeps suffering from the skin. You know, on those days, all what we say, his skin is bad or good, we don't put PASI score or any score at that time. So this is how I prefer always put the real notes to discuss with them. He was also on a Plaquenil, and we know Plaquenil is controversial in psoriatic arthritis. However, he had it. The main thing, that's what I'm saying, he was improved on adalimumab, was good for the skin, but not for the joints. So his joints are the priority, his pains are the priority. Although he preferred to have all round improvement. Then we put a summary that he was 4 years on etanercept. One time I first saw him. His back pain particularly is the one he concerned about and seems to get better with Enbrel and come to me only for renewed prescription at that time. But then I say, look, let's look what happened with your back pain, or how we assess your back pain. This is the pain of X-ray of the cervical spine. There is a disc disease, because quite often we might find a coincidental finding of disc disease or some other abnormalities could explain the back pain, and the back pain is not related to psoriatic arthritis. That's always for clinicians to have open mind about any other secondary cause for the symptoms. For the psoriasis, it's much clearer because it's psoriasis there on the skin. But for pains, we always need to check the cause of the pain. So then we have done X-rays, and these X-rays, it looked to you having many abnormalities, as we'll go through them one by one. But we have some investigations, and including the DEXA scan and some hormonal check as well. Because I don't know if you have noticed, I'll get you the X-ray back, there is a fracture of the L1 above. He had a fall and he was told to have fracture. So why is this a fracture? And there is a disc prolapse there, or is it just axial disease of psoriatic arthritis? Going deep into the story, he had a fall that led to fracture. But we know rheumatoid arthritis is mentioned in FRAC's system that it is a risk factor for osteoporosis. If you take the data of a FRACs, they always took the rheumatoid arthritis cohort from the Western countries, and many of them above the age of 50. So the chances to have rheumatoid factor as additional risk factor is there. However, other inflammatory arthritis, do they have the same risk? Other age or representation, do they have the same risk? So should I say this is again osteoporosis secondary to psoriatic arthritis? That we have to be careful with, and we have to further investigate. So that's where you see the fracture. That's where you see sacroiliac joints, difficult to see any residue of them. And that's when you have this disease. So coming back to psoriatic arthritis, try to answer the first question. Is osteoporosis in psoriatic arthritis, is it as common as in rheumatoid arthritis? This cohort saying, no, it's a lower prevalence compared to rheumatoid arthritis. Indicators of disease activity might not show a higher prevalence. This can have many factors. The presentation of psoriatic arthritis, we see them usually at younger age maybe. And secondly, they have extra osteoblast activity. That's why it might affect DEXA scoring. However, during my work in UK, we did not search the psoriatic arthritis. We didn't have data at that time. We just only look at rheumatoid arthritis. So in conclusion, I felt this is maybe not directly related to psoriatic arthritis, and we need to investigate for a secondary cause. And looking at the secondary cause, and then we found a secondary cause, and I started the patient on Prolia. Till last month, I have a patient who was denied the Prolia because they are on adalimumab, and we'll come to this issue again. We started denosumab and testosterone. Apparently, he had orchitis at a young age, and his hyperspermia, and we got endocrinologists involved and other specialties, and he is on testosterone to manage the secondary osteoporosis. So I'm glad at least we could identify this not as part of secondary to psoriatic arthritis. Are we safe to give denosumab with Enbrel? This issue came about 2 years ago, and is there a risk of additional biologics? Particular denosumab and biologic therapy is done with the Humira, but this guy was on Enbrel. So what we say, there is no significantly increased risk of infection of denosumab with other biologics compared to biologics alone. So it's my routine practice. It's to give Prolia routinely with other biologics, no doubt about that. Now we come to the decision. This guy is still using a lot of creams and gels. And at that time, we saw him in 2017, the Grappa just about to expand the 6-domain principle. And I say, look, are we managing the case correctly? Still having psoriasis, does it still considered as a risk for further comorbidity like cardiovascular or some other ones? So do we have other options? It's a challenge to me, but the patient just continue with that. Occasionally ask if there is anything else to do. To the point I say, look, we might need to try something else. Pains are better in general. This is if we look at the 6 domains started at that time. And peripheral arthritis, he seems okay with it. Enthesitis, okay. Dactylitis, he did not have any dactylitis to mention. Axial disease, he is better in terms of back pain, but he's still sensitive to delay of a treatment. So the back pain is not related to a broken spine. That pain is gone at that time after a few weeks. But he has pain sensitive to biologic therapy, and he's very educated, give a true good account of his symptoms. So I considered that maybe his pain is inadequately controlled. He has little nail changes. They are not the majority, but a lot of extensor skin patches there. So we say, let's then we are in the era, we have many modalities of treatment. Let's go for one of them. And I suppose we could have voting system, but we don't have. But raise of hand, which option you would choose from these 6? Yes? Cannot hear you. IL-17? Okay, any other thoughts? Yes? رقم 1. Okay. Yeah, it's an option, but I tried first to increase methotrexate as to see if we can just go with the flow for the time being. Then he's still like minimal or no pain axial, but a lot of extensive psoriasis. We continue to be in the area of dissatisfaction as some domains are not doing very well. However, he moaned from time to time that his skin is annoying and he might need to other modality, although he's happy with the pain somehow. So his extensive psoriatis is coming like the area of 8%. That's rough account of what he is suffering from. So it's not little, it's not very massive, extensive, but it's annoying. So at that time, because we are happy in the era of so many molecules coming in, and we suggested IL-17 correctly, but it's one of the first patients I try ixekizumab at that time, just license. Disappointingly, with the promising of IL-17 ixekizumab, he came to me to say his psoriasis is clear, but he has bigger painful patch of injection. You just felt bad because you clear one thing, you add another thing, and he had 2-3 injections. And sadly, one of these percentages of people that might have reaction. And he said, it's very painful patch, very painful skin. So he made me feel, put my head down, oh my God, what to do then? Another new adventure, which is just licensed for psoriatic arthritis at that time, tafasitinib. We know at that time it's licensed for psoriatic arthritis, but there were no psoriasis data presented well. And we gave it a chance, and it's oral, and he to give up injections and this sort of thing. And he was disappointed that he did not feel anything better. Everything goes worse. That's another 2 months. Now he start to lose faith and confidence in our practice. And what do we do? There is no magic despite all discoveries. So despite the line goes to the right in terms of new advances, he still feels go back to etanercept as the best option, which is #1 in the biologic era. I have to use my brain more carefully here and say, okay, how to manage these cases and what to choose. Another TNF, he kind of partially responding to 2 of them with certain domains only. Another IL-17, the IL-17 he failed is not failed, he had side effect. IL-23, he has significant axial disease. PDE4, same principle. Another JAK, from his point of view, no way. So the challenge is it to try a new challenge of therapy, or we got back to some familiarity? At the point we start ixekizumab, we are familiar with secukinumab for a couple of years. And we only stopped there because of side effect. So I think familiarity in a class could help us in that sense. But to consolidate that idea, again, this is a paper I show, although a bit later than that date, but there were a few abstracts start to appear in Euler and Upla, and is about persistence and retention of biologic therapy in people with psoriatic arthritis, and secukinumab does seem to be the best flying of all biologics. So that's encouraged me, and a product I tried it for 2 years with other patients. I say, let's go back to that principle. So if I show you here the sacroiliac now, difficult to see any remnant of that joint. It's all like nearly ankylosed, stage 3 at least. And these are the spines we show you. One of the problems here we used to have is if the patient labeled psoriatic arthritis, how you classify axial disease and how you tell the insurance, this is, they need from you PSOC or even DAS on those days, and there are not much of peripheral joints to account, is only axial disease. I had a lengthy argument for about an hour one day with the insurance. I say, look, I want to label this guy as ankylosing spondylitis plus psoriasis rather than psoriatic arthritis based on the requirement you ask. However, at the end, they have shared pathogenesis in many ways. So if this is a group of these spondyloarthropathies and how there is overlap between them. And the main question, should I follow this patient with the BAS dye or keep doing PSOC, or more recently DEPSA, I do. And anyway, we could overcome, and also the confidence in secukinumab is covered the both conditions compared to IL-23 or PD-L4 or other ones. So at the end, we started secukinumab, and he was a stable and very happy with it because he has both the skin cleared as well as the back pain, very little, if any, which could be attributed to any secondary cause. He feels that nature of inflammatory back pain is not there, only occasional twinges of pain, which is not inflammatory sounding. So we come back to the sixth domain principle here, and I think with axial disease, we are doing well. For the skin, he feels great because I showed, Dr. Fatima showed the slides just like the skin. I take his accounts very, very considerably. He's a very clever gentleman. So when I say no joint, no skin lesion, just like all disappeared. And the nail changes again. He did have some pitting and little onycholysis. He feels they are also better. And I feel we are fulfilling the sixth domain to the best possible. I don't know if there will be a miraculous treatment in the future, even revert the skeletal or bone changes. That's a bit of a dream now, but at least we are fulfilling most of these domains. According to yesterday's talk about the updated Grappa guidelines, he doesn't have any associated symptoms. Cardiovascular, he's a bit overweight. I keep warning him about that, and he's hypertensive. So the six domains are our challenge to achieve patient's target to enjoy. And I think that's my message. However, in between, all these evidence in terms when to diagnose things and when to treat things to be taken very carefully with any patient rather than just taken for granted. He was called psoriatic arthritis. Quite often we find different findings. And this is how I do reporting, because I do it in the old system of reporting. It was very poor system. We have now a new electronic system. Doesn't seem much better from the previous one apart from being more colorful. So I put my documentation very clear in a report, send it to insurance. That's how I put the scoring system. And so he continues till now for about 2 years, and quite happily, both myself and himself and his visit are more than a routine. Hi, how are you? How are you doing? You went to travel somewhere or not, and this sort of thing. And thank you very much.
Thank you very much, Dr. Athir. And as we said earlier, we'll take the questions towards the end of the local cases discussions. We're moving on with the next case with Dr. Hussein Abd Daim from Abu Dhabi. Dr. Hussein Abd Daim is well known to both rheumatologists and dermatologists. He's a senior consultant dermatologist at the Noor Medi Clinic in Abu Dhabi. And he's the previous also head of department at Al Mafraq Hospital. Dr. Hussein is going also to discuss one of the local cases and the challenges that we see on our daily practice. Thank you, Dr. Hussein, for being with us. Mic is yours.
It's the time to
just a minute because maybe I have, yeah, okay. And let me do my Actually, this morning I'm not going to present a case, but after all these talks about the importance of collaboration between the dermatologist and the rheumatologist for the easy early identification and management and collaboration in management of such cases with multiple comorbidities in psoriasis, mainly psoriatic arthritis and other comorbidities as well. I think I have took the chance to talk more to my colleagues, the dermatologists, to just mention some of the facts about what's the role of the dermatologist in cases of PSA, how we are going to screen it, how can we early identify these cases, because all of us knows that just a minute, let me to do. All of us knows that psoriasis usually in most of the cases appears many years before the joints has been involved in cases of psoriatic arthritis. We consider the dermatologists as gatekeepers for identification or early identification of cases of psoriatic arthritis. Early identification is very important for the outcome of the treatment of psoriatic arthritis and disease activity control, as has been, we have been taught this a lot from our colleagues, the rheumatologists, many times, and even they show us many of these cases. Just I'm going to mention that psoriatic arthritis, it results from the chronic joint inflammation associated with psoriasis and is clinically highly heterogeneous, as has been beautifully illustrated by the Grappa domains by our previous speakers. There are multiple or there are a heterogeneous group of different joints affection, either it is peripheral or axial or whatever. But PSA is a seronegative arthropathy that can develop at any time during the course of psoriasis. However, in almost 80% of the cases, psoriasis precedes the onset of psoriatic arthritis by many years, up to a decade. And as all of us know, that patients with psoriatic arthritis may develop either peripheral arthritis, axial disease, dactylitis, enthesitis, what I mean, inflammation of the digits or inflammation of the insertion of the joint of the muscles and tendons at the bones, this enthesitis, at any time during the course of psoriatic skin disease. This is, I mean, that psoriatic arthritis is very heterogeneous group, and it does represent by many presentations as peripheral arthritis, axial disease, dactylitis, enthesitis, in addition to the skin and nail involvement. These are the 6 domains which has been approved by Grappa, and I think every one of us, either the dermatologist or the rheumatologist, aim to control this, and as Dr. Athir mentioned, make the patient enjoy his or her life. This on the left hand side, this is tendo Achilles enthesitis. This is how dactylitis appears, and this is the axial disease, this sort of place. I think I'm not presenting something new for all of you, but as I mentioned before, psoriasis usually precedes the appearance of psoriatic arthritis by many years. And there is some photos to show how the psoriatic plaques appears, as well as the extensive nail involvement as well. In this case, this photo shows both psoriasis, nail involvement, psoriasis of the skin, nail involvement, as well as this dactylitis, associated digits. So I think this has 3 domains of the Grappa domains. Again, the nail changes are present in almost more than 2/3 of the cases of psoriasis, and there are different clinical manifestations of psoriatic nail affection. Either it does affect the nail plate or the nail parenchyma itself. I'm not going to go into this. We know how to measure it, and how by the NAPSI score, and how to measure the improvement or the degree of affection, as well as the improvement after treatment for the outcome. Again, sorry. Again, this is the enthesitis, dactylitis and enthesitis. Sorry, this is the dactylitis, how it is almost in half of the cases of psoriasis. They have inflammation of the digits, either the fingers or the toes. It is uniform or fusiform swelling of the digit. Those cases are associated as well with psoriasis of the nail. And usually psoriasis of the nail is a very good indicator for the presence or the future development of psoriatic arthritis. It is very closely associated. Again, this is the axial disease or the axial involvement or spinal involvement of psoriatic arthritis, which is almost present again in more than half of the case. Patients with a long history of psoriasis are more likely to have psoriatic arthritis than those who have only psoriasis for a short time. What I mean that the longer a patient has psoriasis, the more likely he or she is going to develop psoriatic arthritis. And as I mentioned, clinically, psoriatic arthritis is characterized by pain, stiffness, swelling, and tenderness of the joints and the adjacent ligaments and tendons, these enthesites. These symptoms can range from mild to very severe, and even the course can be very slow, or sometimes it is very quick, very rapid, and joint destruction can happen in a very short time. So different presentations with different courses with different acuity can be seen in cases of psoriatic arthritis. It is really a very tricky disease. Again, the resolution is variable and unpredictable, ranging from mild inflammation to severe destruction and even this debilitating arthropathy. It is like rheumatoid arthritis that it may create disease burden similar to rheumatoid arthritis and sometimes even more. And patients with PSA are at increased risk of other comorbidities like higher mortality compared with the general population. So the presence of psoriatic arthritis add to the comorbidities associated with psoriasis more and more. PSA occurs in about 1/3 of patients with psoriasis. It varies between different authors and different publications, but it varies between 10 to 25, even 30% of cases of psoriasis are associated with psoriatic arthritis, although many reports report documented higher rates. And this is different reports, the yellow ones, which indicate the high percentage of PSA among patients with psoriasis, but it ranges, as you see, very big variations from 7 up to 30% of cases, or even this 48, which is very aberrant. But we can say generally 1/4 to 1/3 of the cases of psoriasis may develop psoriatic arthritis. Dermatologists should be encouraged to actively screen patients for signs and symptoms of PSA, as early detection of this arthropathy may improve the patient's outcome through early and appropriate treatment. Recent evidence shows that PSA is underdiagnosed by the dermatologist, no doubt. We can see that psoriatic arthritis are usually under-recognized, and 20% of the PSA develop clinical deformities and damage resulting in functional disability, because we usually, or we were, I think nowadays you are more alert about that, but 20% of PSA can develop clinical deformities due to delayed in diagnosis. And after 10 years of follow-up, more than half of the patients have more than 5 deformed joints, which I think it is a bad outcome. About 27% with early psoriatic arthritis has at least one erosion and presentation to the clinic, and almost 47% developed erosive disease within the first 2 years. This is some of the data just to show that delay in diagnosis and detection of psoriatic arthritis usually have a drastic outcome, and it does may lead to some disability and even make the treatment more difficult, and the outcomes are not that pleasant ones. There is no commonly used PSA screening tool in the dermatology practice, but there is a need to better define how to identify psoriasis patients at risk of PSA who should be referred to the rheumatologist for further diagnostic investigations. So there are some issues which are relevant to the dermatologist in cases of PSA. I'm just going to touch some of them. Are there significant risk factors for PSA among psoriatic patients? Of course, yes. Family history of psoriatic arthritis, especially first-degree relatives, is a very high independent risk factor for the development of PSA. The presence of HLA B27 antigen associated mainly with the axial form of PSA. Thus, routine screening for HLA B27 is not recommended due to its low prevalence. The other issue is it possible to identify psoriasis skin phenotype that would be associated with a high risk or a higher risk of developing psoriatic arthritis? Yes, there is no clinical type of psoriasis that's significantly associated with the development of PSA, including pustular psoriasis of palms and soles. But the following localization of psoriasis are associated with increased risk of PSA: the nail involvement, the scalp involvement, as well as the intergluteal cleft. Just last week, I had an adolescent, almost 15 years old, young lady, 15 years old girl, and she has only these 3 areas which are involved by psoriasis for the last 3 years. Of course, after starting to manage her, immediately I transfer her to my colleague, the rheumatologist, because I'm pretty sure either she's already had psoriatic arthritis or she's going to get psoriatic arthritis. The risk of PSA increases with the body surface area involved. However, limited skin involvement does not rule out the presence of PSA. Again, the third issue which concerns the dermatologist during cases of PSA are if there is any clinical cutaneous signs predictive of the severity and the destructive course of PSA. I don't think so. There is no skin phenotype predicting the severity of PSA. Again, if there is any extra cutaneous clinical signs which must be routinely screened by the dermatologist so as not to miss PSA in a patient with psoriasis, yes, we usually ask the patient for peripheral inflammatory pain, or even to examine if you have some of the skills, axial inflammatory pain, dactylitis, batic or psoriatic pain, morning stiffness of the fingers, and low back pain. I think these are the symptoms and signs which are very important to ask the patient with every single visit with psoriasis in an attempt to early identification of those patients with psoriatic arthritis. Again, which PSA screening questionnaire should be recommended in daily dermatology practice? There are many screening questionnaires, and every one of them have different specificity and easy to apply or not. There are many, as I mentioned before, like the ERP, the GPAR, the PS, the PASC, the PAC, the PACE, the PEST, the TOPAZ. There are many. I'm not going to go deeply into this, but I think the most commonly used by the dermatologist is the PEST one, which is the psoriasis epidemiology screening tool. It's very easy, just 5 questions, which took very few minutes to be responded by the patient, and usually it yielded high positive results. As I mentioned before, there are just 5 questions with this draw, and the patient can do it just in few minutes. Have you ever had any swollen joint or joints? Has a doctor ever told you that you have arthritis? Do your fingernails or toenails have holes or pits? We try to identify psoriatic nail involvement. Have you had any pain in your heels? Have you had finger or toe that was completely swollen and painful for no apparent reason? And then the patient can even mark which joints he has some problem in. I think this very easy one, and took very short time and gives good information about early screening. I'm not going to go how to interpret, but it is very easy. If anyone wants to do it, I think it is very easy to learn. Which imaging procedures should be used to diagnose PSA? Although it is out of scope of the dermatologist, and what's the role of the dermatologist in prescribing imaging procedures? Usually we did not do that, but the following imaging techniques are recommended to diagnose PSA. I think the dermatologists are more clever and more experienced to ask for what imaging technique would be suitable to detect PSA in different joints, but generally they are using the standard X-ray for hands, feet, and nodules, the ultrasound for the pieces and joints, or joints depending on the location, and MRI for the spine and sacroiliac joints, as has been shown by the previous speakers, our dear rheumatologists. When they explain their cases and discuss the cases, they show us many of these imaging techniques. Dermatologists, depending on their experience, can prescribe all or some of these examinations, or can discuss them with the rheumatologist. I personally, I didn't ask for, but usually I collaborate with our rheumatologist, and usually they discuss with me the results of these imaging techniques. So when the most important question, when the dermatologist is going to refer the case to the rheumatologist. There are many opinions about this, but generally speaking, or what I'm doing, generally speaking, the dermatologist should refer the patient with psoriasis, with suspected psoriatic arthritis, if arthralgia, if this patient has arthralgia, joint pains that does not settle, or if the patient has any of these inflammatory features. Early morning stiffness, which become better with exercise. If the patient has swollen joints, enthesitis, dactylitis, low back pain, buttock pain, heel pain, or foot pain. All these symptoms and signs, I think we should refer the patient to our rheumatologist. I know they are very busy, but they are the ones who are going to help us assessing the disease severity and putting the goals for the treatment and many, many other things, which are usually very important in decision making for what's the optimum treatment for those patients. Of course, this is my last slide to show how the collaboration between both dermatologists and rheumatologists. Usually the dermatologists can screen for PSA in at-risk population, but if you have any suspicious, we are going to refer him to the rheumatologist who is going to confirm the presence of inflammatory arthritis in patients with psoriasis, and is it psoriatic arthritis or other type of arthritis, because not every single case of arthritis in psoriatic patients are psoriatic arthritis. Thank you.
Thank you very much, Dr. Abdudayim, for enlightening our dermatology community and when to consider referring to rheumatology colleagues. Now we're moving to long-term and sustainability cases of biologics. And our next speaker is Dr. Giannina Stataci, who's experienced rheumatology specialist in Al Reem Hospital in Abu Dhabi. She has special interest in treatment of inflammatory arthritis and lots of experience in musculoskeletal ultrasound and vasculitis. She has 2 fellowships in ileal arthritis research at the AMC in Netherlands and at the University of Glasgow in the UK. She worked here in lots of hospitals in the UK as a rheumatology consultant and practiced in different countries. The floor is yours.
Thank you very much for the lovely presentation. I was given the task to touch 2 topics. One of them was long-term retention of biologic medication, and the other one was recapturing efficacy. So I prepared 2 cases. I hope there's enough time. The first topic, long-term retention of biologic medication. I will start by shortly introducing the EULAR recommendations for the management of psoriatic arthritis. I'm pretty sure everybody is aware of it. But moving on to the first case, this is a 32-year-old man who was referred from the dermatology clinic after the dermatologist discovered 2 swollen toes. The initial presentation in the rheumatology clinic, he came with knee pain, dactylitis in the toes. He had quite extensive nail psoriasis and plaque psoriasis affecting knees and the scalp. Morning stiffness lasting for 2 to 3 hours. And interestingly, he has been treated for psoriasis in other clinics for nearly a year, but nobody asked about his joint pains. DAPSA was 46.7, not quite a high score. And in terms of laboratory investigations, his CRP was elevated with a normal ESR rheumatoid factor, CCP were negative, HLA-B27 was negative. And on imaging, most X-rays were normal. And interestingly, MRI of the SIJs was normal as well. We got a rejection from the insurance to scan his lumbar and thoracic spine, so we had to do with the MRI of the SIJs. But I did perform an ultrasound scan, and we discovered synovitis in the NTPJ, and tenosynovitis and Achilles tendonitis in his right foot. So I think he pretty much covers the criteria to diagnose him with psoriatic arthritis. In terms of treatment options, if you look at the EULAR recommendations, the first line should be a synthetic DMARD, like methotrexate, especially in those with polyarthritis and raised inflammatory markers. So this is what we did. However, 4 months after his initial visit and a few missed follow-ups, and on 15 milligrams of methotrexate, clinically his ankle pain was still there. There was still a bit of tenderness over the Achilles tendons, and his CRP mildly dropped to 10. On further scans, he still had persistent tenosynovitis of the Achilles tendon and enthesitis, and he slightly started to develop irregularities of the cortical bones, but no erosive changes. His DAPSA score was slightly better. So what do we do next? If we look at further recommendations, I think both Euler and Grappa agree that we should consider either an anti-TNF, an IL-17, or an IL-12, 23 biologic. I usually discuss all these options with my patients. We put on paper pros and cons, and it was the patient's decision to go for secukinumab. 3 months after his first dose, a remarkable improvement. There was no sign of active synovitis. There was no more morning stiffness. He resumed gym, and his DAPSA score indicated remission. 3 years, fast forward, he's still fine. He's still on 150 mg once a month. DAPSA score shows remission. He stopped methotrexate. There is no use of DMARDs. So I think this is a very happy case of a biologic naive patient that responded really well to medication, and he's doing well after so long. The next case will be, I know I'm a bit quick, recapturing efficacy. This is another very interesting case. One of my first cases when I moved here to the UAE. A lovely 56 years old patient that came to my clinic brought by her son. She had so much pain everywhere. So knee pain, the right knee was especially bothering her with swelling and limited flexion. But on examination, she had quite serious hand deformities, active synovitis, Hall's valgus with synovitis bilaterally in the feet, and quite big plaques of skin psoriasis on her hands and knees. And she also had pitting in the nails, but that was not her problem. Her problem were the joints, which were affecting her quite a lot. To give you a bit of background regarding her disease, she was diagnosed initially in 2011 with what most of us know here, like rheumatism. So there was no specific diagnosis. She had used anti-inflammatories. She had numerous steroid injections, physiotherapy, topical treatment for nearly a year, and eventually she was started on DMARD, and she went through methotrexate, sulfasalazine, and this is what I was able to capture from her or the family, because there was no report available, and at that time we didn't have any synchronized databases. From what I've gathered, she had a couple of injections, which after digging further, it was adalimumab and golimumab, and the last biologic prescription, I don't know which one was that, was in 2016. In terms of investigations, the ultrasound scan showed active synovitis in the small joints of her hands. There was a significant effusion in the knee, enthesitis, erosive changes on top of degenerative changes were seen in all compartments. Labs show elevated inflammatory markers, a negative rheumatoid factor CCP, ANA, and a negative HLA-B27. I don't have any images of her spine. So before we move on to my decision on what to give her next, I just want to present this lovely slide that show biologic retention data and how people are doing when we switch from one TNF to another. So to put it shortly, on the third TNF, the retention rate is really, really low. So this lady already had 2 biologic medications. It doesn't feel right to give her the third one, especially because the discontinuation of a first anti-TNF due to inefficacy in this particular study was around 30%. This is the slide that will give me an opportunity to make you understand why I've chosen secukinumab. If you look, let me see if I can find the pointer. Right. So if you look at the use of secukinumab in the anti-TNF naive medication, anti-TNF resistant population is doing really well. And this was particularly exciting for me to see that the data in patients who have tried more than 2 or 3 anti-TNF, secukinumab did really well despite them failing so many. And this is data from the Future 3 study. In terms of real world retention of secukinumab, in terms of remission and response rate, this is some data from the EuroSPA study, and I think it's currently the largest real world study, and it has included more than 2,000 patients with psoriatic arthritis. And the effectiveness of secukinumab leading to low disease activity was around 70%. So these patients did really, really well, and significantly better than those who had 1 or 2 prior biologic medications. So this lady was started on secukinumab. In 2017, coming from the UK, it was not approved yet. So I did not start her on 300 mg. I started her on a safer dose of 150 mg with a loading dose. And she did well. In 3 months follow-up, obviously she still had persistent deformities in the hands, but there was no sign of active synovitis, at least apart from the chronic synovitis, which was not active. She had regained some of the mobility in her knee, and I added a bit of physiotherapy to speed things up. CRP was normal, DAPSA score was 8. She was on methotrexate, still 10 mg weekly, on and off use of anti-inflammatories. And the most exciting part was that on the ultrasound scan, there were no features of active synovitis. 12 months follow-up, still on secukinumab, she was doing well. No recent flare-ups, DAPSA show remission. There were no skin psoriasis except for the nails, but she was referred to dermatology and started using topical treatment. Normal labs, the dose, I kept it unchanged of 150 mg. I'm pretty sure you're all familiar with this. Once the patient feels better, there's no more pain, there's no need to come and see us. So 18 months, fast forward, she didn't come for her appointment. I did call her at that time and she said she will rebook, but I have not seen her for 9 months after that. Now, early 2019, she came back. She came back with a big flare-up. She came back with synovitis in her hands, ankles, the right knee was playing up again. Psoriasis came back on plaques on both her knees, morning stiffness, elevated inflammatory markers, and of course, the ultrasound scan showed active synovitis in her hands. So we had a really long chat about what we should do and that she needs to go back on medication to prevent further deformities. Interestingly, she was not as reluctant as she was the first time I gave her a new biologic. So she just agreed to go back on secukinumab, and I restarted, but again with the loading dose, still 150 mg. This is a slide that from a study, but that this was done in psoriasis. In psoriatic arthritis, we don't have any trials or any studies to show the efficacy recapture data. But in psoriasis, secukinumab did actually really, really well. So despite stopping it for around 6 months, patients responded nice. And there is a good percentage that achieved PASI 75. 3 months follow-up for my patient, she was doing good. So remission, there were no sign of clinical synovitis. There were normal inflammatory markers. I have not added methotrexate this time. So she was on single monotherapy with secukinumab. June 2021 was the last time I saw her, and she was still doing well. She continued with the same regimen. There were no DMRs, no use of anti-inflammatories. She did have very small patches of skin psoriasis on the left knee, and I did discuss increasing the dose, but she was a bit reluctant to do it when I told her she has to take 2 injections at the same time. She's happy using topical treatment for the time being, but as long as she's happy and she knows her options, we kept her on 150 mg. If you'll ask me why I have not continued with methotrexate in view of the skin lesions, well, firstly, it was probably patient's preference not to have an added medication, considering her joints were fine and the skin wasn't bothering her as much. And data on the use of secukinumab with or without methotrexate is very reassuring. So these patients, even if they don't take the methotrexate, they still do very well in terms of ACR 50 through 4 years, regardless of the use of methotrexate. This is another interesting slide, and it's one of my last ones, regarding the sustained improvement in ACR 20 and 15, 5 years in patients treated with secukinumab. Obviously, those that are treated with 30 milligrams, those slightly better than the ones on 150, but nonetheless, it's very reassuring that these patients can continue long-term with this biologic medication, and they do really well without losing the efficacy. Obviously, the main goals in treating psoriatic arthritis, we need to control symptoms, we need to prevent structural damage, and we need to improve the quality of life. I will not discuss the clinical benefits of secukinumab, but I would like to point that this medication does particularly good in patients who have failed previous biologic medication, especially anti-TNF, and we can still use it irrespective of concomitant use of methotrexate. There is still a need for patient-centered approach. So we still don't know which biologic to choose first or second or third. I think more clinical studies are needed to help us choose the right one from the first visit. Right. Thank you very much.
Thank you very much, Dr. Ganina, for the very interesting data and reminding us of the sustainability of secukinumab. I'd like to introduce next Dr. Aqil Ghanem, who is a consultant rheumatologist and head of the rheumatology unit in the Department of Medicine at Mubarak Al Kabir Hospital in Kuwait. Dr. Aqil is a supervisor of different residency program for the Kuwait Institute for Medical Specialization and clinical tutor for the medical students of the University of Medicine in Kuwait University. We're excited to hear some of the cases from Kuwait, and we're glad to have our Kuwaiti colleagues with us today. So the floor is yours, Dr. Aqil.
Good morning, everybody, and thank you very much for inviting me today, and thanks for Novartis for the sponsorship. I'm going to share today with you a very severe case of psoriatic arthritis. I'm going to present actually one case today, which I'm sure that a lot of you have same or maybe worse. And the reason of patient today is I'm a bit, interested to hear how would rheumatologists treat with all the guidelines that we have available for us now, and how sometimes people get in a dilemma of what to do next. So Mr. Hamid, he's a 39-year-old gentleman. He has psoriasis since 2010. His first visit to our clinic was in July 2020 with extensive psoriasis on his palms, feet, torso, head and neck. He had severe joint pain, peripheral and axial, with inactivity, stiffness, and swelling in some of them. He didn't have any history to suggest inflammatory bowel disease. He has no history to suggest uveitis. And also, there's no history to suggest recurrent sexually transmitted diseases. So as we said, psoriasis since 2010. He also has bronchial asthma since childhood, which usually makes it a bit tough for us as rheumatologists using of the pain. He's been treated with Symbicort, and he's taking paracetamol as needed as non-steroidal bronchial asthma when he needs it. He's married with children, he has an office job, and he's not successful. And he has psoriasis in multiple first-degree products. So his physical examination showed that his blood pressure is a bit on the higher side. It's a little bit tachycardic. Was a bit overweight. And the rest of his general examination was unremarkable. MSK and skin examination shows opacity of 15, body surface area, 12%. He has many tender joints. Well, some of them were swollen, and his CDAI is 32, which reflects severe active polyoarthritis. So from the first visit, we did conclude that we have severe psoriasis. So what did we do? The good advantage here in where I practice medicine in Kuwait, that access to biological therapy is relatively easy. So we thought to start him on biological therapy very early. So we did start first treating his severe psoriatic arthritis with molexicam. And this is one of the non-steroidals that is very rarely can exacerbate asthma in patients who have multimodal. So we decided to give him a full dose of paracetamol over the clock. And we screened him for latent TB, viral hepatitis B and C. And we also vaccinated him against influenza, pneumococcus. We were testing him for his also status to see if he's vaccinated. And we decided to go with biological therapy, preferably. And with that, we probably were following the European guidelines when we saw that skin disease is very, very active. So, seen in mid of July 2020, the R17 was started. And we seen him 3 months later, and this is where we really could find a effect on the joints and conclude if we should continue or change. Earlier than that might be a bit early in rheumatology. When we want to assess biological therapy, we usually wait for 2 to 3 months. So when we saw him in October, his skin has improved up to 90%. It's very impressive. However, his joints improved 50% when we counted points, and it was still stiff in the morning, and his RP was 42, which we didn't have a basic RP when we saw him the first time. And creatinine showed that his kidney function is on the high normal, so he's very close to get an abnormal function. So what would you do next? Now, this patient improved remarkably. Once improved 50%, he has a severe disease to start with. And now our choice of giving him non-steroidal is not there because we don't want to make his kidney worse. Question was here what to do. Should we continue? Should we add something? Well, as this is a virtual meeting, I think it would be maybe a bit hard for me to hear questions or answers. So let me tell you what we did. So we decided to continue on IL-17 monthly, 50%. I think for me was a patient with severe disease to be achieved within 3 months. All right, and we decided to give him a methylprednisolone 120 milligrams injection. And we decided not to give him a non-steroidal anymore, and we thought to see him now in 6 weeks rather than 3 or 6 months. Now, for us as rheumatologists, we have always heard that corticosteroids, especially high doses, have a potential risk of flaring psoriasis. Honestly, I haven't seen it in my life, and I use corticosteroids sometimes, well, maybe kind of frequent in some patients. Psoriatic arthritis and non-steroidal is not an option. I haven't seen it. And when I finish my presentation, I would like to hear from our colleagues from dermatology if I need to have better advice about this and He came in January of 2021, joint still active, remained on 50% improvement compared to baseline. His skin is 90% better, except for his palms and soles. Still much better than baseline. And unfortunately, we actually so what would you do? We switch to another IL-17. Should we switch to an anti-TNF therapy? Should we switch to an IL-23? Should we add methotrexate or flutamide or something else? Well, we sat with a patient and we discussed the options. And we told him that this is what we have and this is what we can do. And I'm the doctor, but at the end, it's a fair decision between us. We will proceed with what you think is convenient. And for me as a doctor, I will tell you if you chose something or you decided to go in a way, I'll give you the best advice of what the advantages and disadvantages. The patient totally refused to switch to another treatment because he felt that skin improvement that has happened to his body was something that he wasn't expecting, and it actually changed his life as the skin lesions were visible to people. It was affecting him in many places, including his private area and stuff. So he felt really much better and was very happy with that. And the pain he can tolerate, as he said, and he didn't want to risk anything to get him back or worse. So he prefers to use topical treatment for his skin and take paracetamol for pain control and use IMD Formoterol as needed. Now, whenever I have a patient with psoriatic arthritis in my clinic, even if he has mild psoriasis, I always try to involve our colleagues in dermatology to guide us to how to treat that, as we have some patients that we treat them with biological therapy or conventional DMARDs. They're going to improve a lot, and sometimes we're left with a few patches of lesions, which could be easily treated by our colleagues in. So this patient preferred that, and in his next visit, we again gave him the Formoterol 120 milligrams IM, and we asked him if his skin got worse, at least initially after the first IM steroid injection, and he said it didn't. And he said that IM corticosteroids usually gives him a heartache relief up to a month. So we mentioned to him that we would be happy to give him corticosteroids as needed. And we think that IL-17 may need a little bit more time to get him better. And although the most of the effect will be 3 to 6 months, but there's some patients that could improve with time. And corticosteroids could be used. We don't like to use them that often, but we have to then. So I think that was really all what my case about, and I'm happy to hear any comments, any advices, any questions about it from rheumatology and dermatology.
Thank you very much, Dr. Aqil. We'll be back to you after the next talk. In fact, we do have one question to you, but we'll keep it towards the end of the talk. We're moving on towards the last case, again, staying in Kuwait with Dr. Abir, who's the head of the dermatology department at Al Adan Hospital in Kuwait. So thank you, Dr. Abir, for being with us. The floor is yours. And after that, as I mentioned, if you have any questions for the audience and those who are attending online, please don't hesitate to write it, and will be answered after this talk.
Thank you, Dr. Anwar. And thank you, Novartis. Today, I'll talk about psoriatic. In the past, psoriasis was a common skin disorder characterized by a focal formation of inflamed raised plaque that constantly shed scales derived from excessive growth of skin epithelial cell. But now, psoriasis is a chronic non-infectious disease that affects people of all ages with no predilection for sex. It is also a disfiguring, disabling, and painful disease involving the skin, nail, joints, and associated with a number of comorbidities. For the patient with psoriatic disease, skin is the only part of the story. We have the invisible and the visible manifestation. Visible manifestation, as we know, the scalp psoriasis, plaque psoriasis, nail psoriasis, palmoplantar psoriasis. But there is also the invisible progressive manifestations, such as 30 to 41% of the patient have psoriatic arthritis, 5 to 25 has spondylitis, 50% have dactylitis, while 35 of the patient have enthesitis. Also, there is comorbidity associated with psoriasis, such as hypertension, obesity, ischemic heart disease, diabetes, and inflammatory bowel disease. Also, the psoriasis can affect the quality of life. Many patients, around 79% of psoriatic patients have diminished of the quality of the life. 12% have decreased mobility. 54% may have depression. 33% they have psychosocial burden. 31% they have decreased work productivity. So the psoriatic disease is a progressive systemic inflammatory disease that impacts the body deeper than the skin. The first case, she's 41 years old, Kuwaiti female, a known case of psoriasis, psoriatic arthritis. She already received many biologic. She received first adalimumab on 2017. She gets a good improvement, but then she has a recurrent upper respiratory tract. For that, they shipped her to ustekinumab on 2019. She received for a few months, then she stopped by herself due to the COVID pandemic. When she came to my clinic, she presented with a multiple psoriatic plaque all over the body, her PASI around 20. She also have involved the scalp. Nail, she has some nail thickening. Also the joint, she was complaining of early morning stiffness, tenderness. So this is her back. You can see that she had a multiple psoriatic plaque over the back, lower extremities and upper extremities. Also, you can check that she has also psoriatic plaque over the scalp. So of course, I refer her to rheumatologist for the tenderness or tenderness over her joints. You can see also that she has nail change, pitting with hyperkeratosis. Patient already started. I start her with ustekinumab on March 2021. After only the loading dose, the patient, she has a great improvement, almost clear. And this is her lower extremities. And she's, you can see that she had a great improvement over the scalp, skin, and even the joints. The second case, he's 50 years old, Indian male, he's a driver. He's a known case of psoriasis since like 6 years duration. He was only on topical treatments. Also, he's a known case of diabetes. He was taking glucophage. He had also obesity. His body mass index was 35. When he came to my clinic, he was complaining of worsening of his rash over the past year. Also, he's complaining of the early morning stiffness that affect his job. He cannot handle the things. When he wake up early morning, it's take longer time to handle the steering wheel of the car. He cannot drive. He cannot handle the things. And even he was very depressed and crying. So this is her skin. You can see that PASI is very high. He has a thick psoriatic plaque over the upper extremities. And you can see his joints that he has a sausage digit dactylitis. You can see that he has hyper thickening of the hyperkeratosis, thickening of the nail. He has a joint, a distal interphalangeal joint swelling. And this is another photo. So the patient, he has psoriasis with psoriatic arthritis. Rheumatologist, of course, I refer him to rheumatologist, but I start him on methotrexate 15 with secukinumab. He get it by Musanada, thanks for them. So after the treatment of secukinumab, his skin rash almost clear. Joints also, he's very happy. The joints swelling, it's much better. He can handle the things. And this is another photo of his skin. This is his hand. And thank you.
Thank you very much, Dr. Abir, for sharing with us those interesting cases. We'll start taking the questions from the, and then we can take our audience. So please don't hesitate to write up your question. Any question here from here? Yes, Dr. Jamal, our rheumatologist here in Dubai.
Thanks, Anwar. My question, I have actually two questions, if I'm allowed.
Sure,
is that okay?
Of course, yeah.
First question is to Dr. Athir Al-Ansari, my friend. Dr. Athir, you have chosen, in your case, Prolia over bisphosphonates. So is there any particular reason? Because we know that bisphosphonates can help with pain with enthesial disease that people have.
Dr. Athir, if you can come up, please, here.
I mean, we had the options. I remember we discussed oral bisphosphonates. I think it's all about convenience in his case. No, nothing more than that. But bisphosphonates is an option. And I talked to him about Aclasa once yearly again. Even if you think there could be some theoretical difference or advantage in any way, I don't think it will be major. I think they are very close in terms of effect. So I take your point on this one, yeah.
Yeah, I'm talking about the effect of bisphosphonates on enthesitis and enthesial.
Or even axial disease, Aclasa
Yeah,
and axial
yeah.
disease.
Sure.
The Aclasa and axial disease, or before that, what was the 3-monthly? Pamidronate, for example. They are not a proven or fully validated, let me say, therapeutic option, although it could add that in case. But he, if you notice, he did not have the spinal disease, just sacroiliitis. There were no syndesmophyte. But I agree. I mean, I thought at some point to label him as AS rather than psoriatic arthritis. But it's all about convenience. You see patients in Middle East, not like in UK, If you give them an option they don't like, they go to the next door rheumatologist. That's what happens. So we have to get them convinced to take at least possible line of therapy. Although this was educated one, but we agreed on. I think there was another reason. I think for all bisphosphonates, he had GI symptoms or something like that. I can't remember.
And just a general question to the Grappa. Is it time now to think about combination therapy for severe cases? What I mean by combination therapy is not sort of severe immune modulatory drugs or immune suppressive drugs, but a combination like, for example, IL-17 inhibitor with phosphodiesterase inhibitors. That might work, you know. So is it time now, or shall we wait?
I think that would be
drugs to come?
That'd be a useful question in today's afternoon session to the Grappa team.
It is sort of research.
I have one case like that.
You have one case. Oh, we'll start with you then.
PDE4 and IL-17 as well. Yeah.
Sounds.
I think it would like strengthen the effect. But that means it's a difficult case and partial response to biologic modality, because PDE4 is not biologic, it's molecular, like methotrexate. Why don't try? The case, I think they had a problem with methotrexate, so that's why we tried PDE4. Yeah, it's judgmental, no data. Sometimes you have to work like that.
Dr. Athir, there's another question about this osteoporosis case.
Can I have a comment, sorry, regarding the combination therapy with, for example, interleukin-17 inhibitors and something like phosphodiesterase or whatever. We had this before when we used to give anti-TNF with the methotrexate. As for psoriasis, I don't believe it will be justified or it will be practical, because we want to get rid of giving multiple therapies for the patients. And we used to reserve the methotrexate for cases which become resistant to anti-TNFs. So I don't think from the psoriatic view that we can do this. I don't know regarding the for severe cases, I prefer to shift to another molecule instead of combination. The only combination which I can give for the patient is topical and radiotherapy. That's all. But to give the patient, expose the patient to two biologics or one biologic and one cytotoxic, I think it's too much. Phosphodiesterase inhibitors, I don't have experience in them, but maybe somebody else would like to answer regarding phosphodiesterase inhibitor.
Now, I just want to emphasize that in arthritis, sometimes things are slightly more complicated, and we do have, even after trying, multiple biologics, you might cover one of the domains, and you might have a patient that responds very well, in terms of axial disease, but still have some peripheral, disease. So they don't respond, in some cases at least, we're left with some dissatisfaction in terms of response, even after having tried, anti-TNFs and IL-17, etc. And sometimes we do need to consider combinations. The problem is obviously safety, and this hasn't been still, studied extensively.
I think this is making us conclude, as we all believe, that treatment of psoriasis is a tailored treatment and individualized according to the presentation, because lots of us as dermatologists, of course, we hope that sometimes that we can have whether a clinical predictors or some hopefully markers that can predict, oh, this is the right biological therapy, or this is the right combination therapy that we can consider for our patients. Because management of cutaneous manifestation is completely different than dermatological. Sometimes, of course, we see the patient is extremely happy from skin. yet if referred to rheumatology, we can see some of other medications being added. So this is why I strongly believe that both of us should work together in order to control our patients. We'll come back to this. Maybe we can ask Dr. Athir about the question that we got online for Dr. Athir.
Yeah, there is a question about, was it essential to add testosterone to denosumab for osteoporosis treatment in your case?
This is not a standardized case in terms of osteoporosis ward. It's exceptional with the secondary. The advice of testosterone is based from the endocrinologist and I think urologist also involved. I have to go with that. It could be enough as a diagnosis for secondary osteoporosis. T-score, I didn't put the T-score there, but it was quite low. That's why we thought, I probably by this time I could not recall the case. Probably he might have stopped prolia by now, but we just felt to give him the advantage of the situation. Yeah.
Prof. Ahmed Abu Jamal?
There is a question. There is a question by Dr. Aqil, which I think is very important as well, because the rheumatologists do use
their assessment of bone marrow lesions in this axial disease. Why don't go for
this, you mean to show the activity, if there is activity. He is overweight. He kind of accepting the judgment rather than get over-investigated. We did discuss this MRI, but the X-ray showing enough, the X-ray done by the predecessor, he say, just let's go ahead with what you think now. He feels he's quite sensitive in recording his response to biologics as what he did before. The pain, the nature of pain he has for back pain due to possible inflammatory is different from any other muscular or sharp pain. So he is giving good account of that. And at the end of the day, there are always other domains to treat. So if I got the inflammation there or not, there are other domains to treat all the time. His account for response to, in terms of back pain, to Enbrel and secukinumab, it was very clear. I mean, when I checked BASDAI at some point rather than PSOC, and the BASDAI is improving according to his accounts. So that will go only for theoretical knowledge, perhaps. And if there is any spinal corner, you might say, well, yeah, but that's one of the, let me say, I don't do everything in terms of academically or book, unless if there is a question I cannot answer. But if the question I can answer straight away, I might not do extra investigation.
Okay, coming back to the osteoporosis management, the same question of Gamal that you asked, you choose this denosumab, but my question this time, this patient already have a previous collapsed vertebrae, spinal fracture, already with inflammatory autoimmune arthritis, and have a testosterone deficiency. Or this patient is not fitting for anabolics?
That wasn't, yeah, that's maybe a good question, but that according to also endocrinologist advice at that time, to build up a bone, but he has regular deficiency of testosterone, and that's anabolic by itself. But I don't know how quick going to correct. I think the spine shape is not going to massively correct rather than prevent another fracture. That's the main point. The fracture in the anabolic one is for high risk osteoporosis with multiple fractures. That's the main indication. When we think they have either genetically very susceptible to severe osteoporosis, that's where the indication is. Is it going to be helpful in this a unique situation? I wasn't sure myself. So I just rely on taking other specialty advice and went that way.
And I think he was on the combination of anabolic and anti-resorptive.
Which is
somehow.
anabolic, yeah.
I mean
yeah, but he means
for Forte or Evenity as options for the management of the spine.
If I can interfere with the rheumatologist.
Is licensed for certain category of patients, which we didn't see that category is typically there. Plus, it is a secondary for a cause rather than just a high risk genetically severe osteoporosis. That's where I use Forteo for that one. So it was a kind of, again, that's part of the difficulty, and that's why we're waiting the questions, but we treat him anyway.
Okay, that's why it's fine.
Yeah. So,
Thank you.
If you
Dr.
allow me
Amir.
to interfere
We're
with the
going to
rheumatologist, I
Kuwait.
have to
Dr.
comment.
Aqil, thank you again for sharing with us your case. One of the common concern for us as dermatologists that when our patients refer to rheumatologists, and we know that some of the rheumatologists, they prefer to start on systemic steroids, whether for tapering dose for short course, or as I think you've done in your case, that was 120 milligram. So just wanted a little bit of a comment on this. When do you consider systemic steroids? Because from our side that we do see sometimes, unfortunately, a flare up of skin psoriasis after given this. We do see the clearance, however, a skin problem that later on may appear.
For us in rheumatology, using corticosteroids in psoriatic arthritis from rheumatoid, patients with rheumatoid arthritis are very sensitive to corticosteroids, even to a very low dose like 10 milligrams or sometimes even 5 milligrams. However, patients with psoriatic arthritis, even if they have less joint involvement, if we have to give oral corticosteroids, we usually have to give a higher dose to see a response, like sometimes 30 milligrams or 25 milligrams to get the same effect of 5 milligrams in patients with rheumatoid arthritis. That's why we really don't like to use it, because we are also managing patients with osteoporosis, and we understand how corticosteroids could be very negative in the bones. But we sometimes really need to use it when we have to. And we don't like to do something in our clinic that our colleagues who are co-managing with us feel that it's that can cause any complications to the organ they're treating. And why I ask this question, and I continue to ask this question in any conference or any meeting that I have with my colleagues in psoriasis to hear more about that, because honestly, over the last 10 years that I've been practicing rheumatology in Kuwait, I haven't seen it any time at all. So that's why I was asking and see, was that a myth in our books that we have studied, or is something that's really seen with our colleagues?
If I can add to what Dr. Aqil said, did you hear me?
Yes, Dr. Hussain.
Yes. Yeah, if I add to what Dr. Aqil asked for, yes, you are right. We are overestimating the flare-up of rebound phenomena of systemic steroids in case of psoriasis. And this has been just published 1 or 2 years ago about a systematic review of the use of systemic steroids in cases of psoriasis for other indications like in psoriatic arthritis. And yes, we have been learned that it is contraindicated, but in real life, I don't think so. And even the article does prove that no problem to use systemic steroids in cases of psoriasis. But as regards the testosterone, the case which has been discussed with Dr. Athir, I am really concerned about the side effects of the long-term testosterone, especially cancer prostate. Thank you.
Dr. Hussain, for your comment. Maybe we can stay in Kuwait. One more question, then we can go back to the floor. Dr. Abir, I see that your patient was on ustekinumab prior coming to you. Now, just wanted to have an idea. Is the ustekinumab Stellaris still being used in your practice as a dermatologist?
Yes, still it's used.
Okay. Now, even with the availability of IL-23, you find patients coming asking for it, or can it just under? Yeah.
Already was treated with other dermatologists, but when she came to me, already I start her on ustekinumab, which is better.
Okay, thank you. Also, I've seen that you still consider for some patients the combination therapy with methotrexate with any biological therapy, or just certain, like for example, anti-TNF, if you're giving your patients anti-TNF?
No, my patient, because he's, as I mentioned, he's Indian, so it's difficult to give him ustekinumab. I couldn't wait until I get the approval of from Musanada for him. So I start him on methotrexate until I get the approval of secukinumab. For that, I start him already on 15 methotrexate.
Thank you very much. Maybe we can hear the feedback about JAK inhibitors and the concern that I think recently been from FDA warning regarding that. So did you find this is something that would worry about as a rheumatologist? You will change your practice. I'm sure that you have lots of patients, whether on tofacitinib or other JAK inhibitors.
Well, I think it's a real concern, but not in a, I would say, in a scientific way. We all feel, as in the rheumatology community, that the FDA, warning was a kind of unjustified. We are aware of the cardiovascular risk and risk of thrombosis, and we're aware of the studies ongoing, in that perspective, and we're till now, lacking the data, and we're waiting for more data with that regards. The real concern is that when FDA, publishes something like that, you start facing some resistance also and some issues with the patients. Our patients are highly educated. Some of them, go and read about the treatments, and it's something that we, at least in my practice, since we got this statement from the FDA, I started discussing this with the patients. So I don't think that the American College of Rheumatology had made the statements and have published a response to the FDA that regards to put things in perspective and in the right context. There is nothing that justifies now any change in our therapeutic algorithms as of now. And EMA, the European medical agency, has been a little bit more reasonable in their, and there is absolutely nothing that has changed so far. So I think that we need, of course, we're all lacking this data, we're expecting more data in that, but there is nothing that makes us change our therapeutic guidelines from now.
Dr. Ziad, I don't know if you have any comment regarding this. Did you started telling your patients if regarding this, their lymphoma concern or cardiovascular concern?
So I think it's all about the right selectivity of your patient. I think the right stratification from the beginning, and you know what drug to give at the beginning. So when you think about your patient, you don't just think about the disease, but you think about comorbidities, age, extra. So probably in an elderly patient who's obese, who got a history of VTEs or family history of VTEs, probably wouldn't necessarily rush to JAK inhibitors. If somebody who got low risks, who's young, probably not necessarily obese, so that's probably would be a good choice if I think oral treatment is a better option, or there is other comorbidities, like sometimes you have a combination or an overlap disease that you might want JAK to cover. Again, the same thing applies to cancer risk. We're not sure yet about JAK. I think it's the same thing applies to how we were with anti-TNF before. Sometimes we need to be careful, 5 years, lack of disease. So as well as cardiovascular risk. So it just applies on the selective patients. And if you got a bit of doubt, there are definitely much safer drugs to think about at the moment available.
Yeah, I mean, I would like to add some historical events. I remember 15 years ago, there was a non-steroidal anti-inflammatory called rofecoxib, Vioxx. Vioxx approved by FDA, and it happened they have trial in colitis, and it has 4-fold higher cardiovascular risk. And that's why it was discontinued immediately, because they are slaughtered badly by the government. And since etoricoxib, Arcoxia, it has been licensed in Europe, but never managed to file an application with FDA, because FDA just rejected that. They don't want to repeat the experience. I think there is a background of this, like here. Again, it's the higher dose of tofacitinib in colitis study. It what showed some increases, not as much as Vioxx, but they are taking their position ahead and not to get slaughtered by the government. So that's why they put this warning. But I agree with Dr. Ahmed. We are using Arcoxia. and we are using JAKs, and for JAKs, studied thoroughly, there is no increased risk in that sense. And therefore, I already select JAK not to give it for elderly anyway. But PSA mainly younger age group, and I don't have big concern, and only worry about Google in this area because they go and do it.
That's the problem what we're facing with our patients. Any more?
I think there are a couple of other online questions we can go through before we finish. Probably I'll ask Dr. Gita, do you have a best option drug for you if you have an axial psoriatic arthritis? Would you select something more than the other, or you have no necessarily one option better than the other?
Well, I would, the case I presented was actually more of an axial PSA, if we would like to, go back to this case. Now, I think that for axial PSA, we're still lacking clear data on which is, better. The entity and the definition, we're still working on a definition of what is axial PSA. And even how to call it in terms of nomenclature. So we don't have yet, we don't know if we should be treating axial PSA in a different way than axial spondyloarthropathy or AS. But as of now, we're still treating it the same way we would treat an AS. So when the main, manifestations are mainly axial, we would still prefer we go immediately for a biologics after failure of NSAIDs, and there is no preference to me here, between anti-TNFs and non-anti-TNFs, I would say, or IL inhibitors, unless there is another domain to consider in this case.
Thank you very much. Dr. Fatma, there's a question from a dermatologist about, who asks, should we avoid etanercept altogether in patients with psoriasis, as uveitis could
avoid
even...
what?
Etanercept.
Etanercept. Okay.
As uveitis could be even silent clinically, or should be doing routine slit lamp examination to rule out uveitis. I think that could be applied to rheumatologists as well.
Regarding etanercept for psoriasis, I don't recommend, because the science is progressing, not regressing. When we start to see the history of psoriasis since 1980, it was known that psoriasis is due to hyperactivity of the keratinocyte due to unknown antigen. Later on, they started to know that Th1 and Th2 could be the reason. Later on, they started to think of interleukin-23 and anti-TNFs, and then started the anti-TNFs around 2004. Then after that there was a turnover after the secukinumab, and now we have the guselkumab and the risankizumab, which are hitting the interleukin-23 P19. So we shouldn't go back, we should go forward. So I don't
Thank you very much.
Yes.
What's about the same question for rheumatologists, Dr. Gita and Dr. T?
Uveitis shouldn't be a concern if it's not active, but obviously when a patient has a, I would say heavy history of uveitis, if you have had recurrent uveitis, and if the last episode, is still is not, if you had, for example, an episode last year, I would avoid etanercept definitely. If I have monoclonal, are efficacious and safe in this indication, and I would definitely go for a monoclonal.
Thank you very much.
Thank you very much. I think with this, we're reaching towards the end of our session. Once again, we'd like to thank all the speakers. Thank you, Dr. Abir, Dr. Aqil from Kuwait. Thank you, Dr. Hussein Abdeldaim. I'd like to thank our speakers here for sharing with us your great cases, and of course, lots of learning points from here. We'd like to thank also those who've attended with us online, and of course, we'd like to thank all our colleagues. Would like just to remind you that the prayer room is next door, starting at 12:14. And of course, would like to thank also Dr. Zayad. Thank you for sharing this session. And we'll be back at 2 p.m. with Dr. Walid. And I would like to tell you to enjoy also your lunch. تقبل الله مقدما. Thank you much and we'll see you later on. Thank you.
Okay.
Hello, everybody. Good afternoon, and welcome to our final session for the day. We have a very rich agenda. We have some people here in the auditorium, and we have, I think, over 100 people online. So welcome back. I hope that you had good lunch. Whoever is not here, maybe you need to have some lunch. So we'll have maybe some 3-4 talks for the afternoon. We'll have a Q&A in the middle and also at the very end. So for now, I'll hand over the mic to Prof. Hallowell to kick off this meeting. Thank you very much.
He's currently having some slight problems with his slides, but we'll hope they'll be fixed by the time I finish talking. Dirk is from Belgium. You heard him mentioned yesterday by Kurt de Vlaam. I once heard Dirk introduced by his friend and colleague Philip van den Bosch as having a much bigger brain than me. And I think that's probably true because Dirk has done some stellar laboratory work over the years. And we heard about some of it yesterday with the suspended mice. But Dirk has also got a special interest in the link between the gut and joint disease in spondyloarthritis. And of course, that originates from those heady days of the past where Herman Mielents and Eric Vase looked at the gut in people with AS and found subclinical inflammation. So he's following on the tradition there, I'm glad to say. So we now have Dirk's talk up on the screen. So it's going to be controlled from Dubai. Dirk's going to talk to it. I would mention that Dirk has to leave after his talk. So if you've got any questions for him, would you put them in the chat while he's talking? And then we'll take a short Q&A session after he's finished. So over to you, Dirk.
Right, good afternoon. Yeah, it's really my pleasure to be here, and I thanks also to the organizer of this session to be here online, unfortunately. So, but I hope for the future we meet in person. So I'm going to be speaking about microbiome. After your lunch, I think your bacteria in your intestine are really actually very active already at the moment. And I hope this slide presentation actually can move forward. Yeah, okay, so the diseases that we challenge and at the topic of today are what I think diseases where we typically have a role for barrier tissues. And this is an overview of my presentation. So I'll touch on these points as we move forward. So the spondyloarthritis and I hope you can see my pointer. But spondyloarthritis is an interesting disease, as you know, because it can come with different flavors. So the actual diseases and the peripheral diseases, and of course the PSA spectrum. And an element I think that is really important to keep in mind is that there's a frequent link with bowel inflammation. It can be full-blown IBD in about up to 10% of patients, but there's also this microscopic gut inflammation that was described many years ago by my colleague Herman Milans. We know this is important actually in the disease activity and also the long-term outcome. So if you have microscopic gut inflammation, you are at risk to develop full-blown IBD, but you're also at risk to develop more progressive disease like ankylosing spondylitis. Next. Am I okay? Sorry. Oops. Sorry. So there are some risk factors for gut inflammation, associated factors, and primarily they link to disease activity. And the concept here is that the presence of gut inflammation or barrier integrity loss in the intestine applies to both actual and peripheral disease, and is actually linked by, for example, early signs of inflammation that you can measure even in the serum or the stool, but also as a result of that, you actually get a leakage of bacteria into the immune system, and you get actually, in some cases, even antibodies against your commensal bacteria. Okay. We think also in the skin is another area that is really quite interesting because the skin is, of course, another barrier. And so the concept is there that barriers are kind of important in the diseases that we tackle. So when we speak about barriers, we also speak about the host is our body and the environment. The environment may be the bad bugs or let's say the commensals that host there. And so if you think about our body, in fact, we should realize that we are actually one bunch of bacteria rather than actually cells. So the number of cells is only 10% human, and we form, in fact, a minority within our own body. So looking into this in more detail, this is, and for the remaining part of my presentation, I will focus only on the intestine. But please remember, you know, there's another immune system also in the skin and in other sides of the mucosal system. In the intestine, what you see here is the bacteria lighted up in red. It is an in situ hybridization for bacteria. You have actually the mucus layer in the intestine, and then you have actually the epithelial cells. And you see here this decomposed, the mucus layer, the epithelial cells. The epithelial cells have a lot of things to do, and I'll come back to that. And then there is a specialized immune system also in the gut. Bacteria are doing good things. I mean, as I mentioned to you, your bacteria after your lunch are actually on full energy. They're providing, in fact, extra energy by fermentation, of course, but they also have a role in the immune system because they actually lead to production of certain molecules, which we call, for example, short chain fatty acids like propionate, and they provide energy to the body. And on the other hand, of course, we know that bacteria can also be bad. So they can be linked to diseases that we tackle, but they also may be important, for example, in our brain function. And in chronic fatigue syndrome, there may be some link there, also Alzheimer, etc., have been linked to that. So a lot of diseases have been linked to certain microbes. Okay, so why do we see that some of the diseases have become more frequently over time, and some of these increased incidence have been linked to certain changes in our microenvironment? And the one idea is that the hygiene hypothesis is that we, when we are not sufficiently exposed to microbes during our development, in fact, we actually are at higher risk to develop certain immune-mediated inflammatory diseases. Okay, and what you see is that some of the diseases typically are in more westernized countries, where you see high antibiotic use, for example, where low exposure to helminths. These are risk factors. The other element is that we have lost good bacteria. Okay, and so over time, because of our way of living, we have lost good bacteria, and that makes it definitely in the Western societies more at risk. And so we know, of course, the stories that certain of the diseases have regional differences. So there may be definitely, the top line is there may be a link to microbes to changes in the frequency of some of these immune-mediated inflammatory diseases. Why is that? Well, because we think there is quite some evidence that there is a quite intimate interplay between the microenvironment, going from certain viruses, certain bacteria, and immune responses. And you see the classical immune responses that we know is type 3 responses, for example, are influenced by certain types of bacteria, which we call extracellular microorganisms. But for example, also helminths may be important. And it's really the fine balance between all these ecosystems that actually keeps health. Okay, we call this immunity by equilibrium in a complicated way. For people that are interested in this view, there's a beautiful article a few years back by Gérard Herbal on this one. Okay, so in the remaining part of my talk, I'll touch briefly on a few topics. So what is the evidence that microbes are linked to disease activity? Well, I mentioned to you that the gut is important, but still we haven't proven that gut and joints are intimately linked. And in essence, this is a complicated slide perhaps, but there are two theories. So one theory is the causal hypothesis, is that in fact you have first gut inflammation, or at least some gut dysbiosis, and this leads to joint inflammation. And there are some arguments for that. And so there are certain risk factors that actually can influence the intestinal barrier. This could lead to subclinical gut inflammation and eventually leading to the disease SPA, because you have translocation of bacteria and the immune system gets activated. The other way to look at this is that gut and joint inflammation may coexist. So in other words, the people that have gut inflammation is just one phenotype of the entire spectrum, and that not all the patients would go to this role. So in other words, you would have a subset of patients that's the gut is important. You would have another subset that's, for example, triggered by biomechanical stress. Okay. And so the truth of that is that we don't really know it yet. At least in some model system, it seems that gut and joint are intimately linked. And we know this from many, many years ago, that, for example, in the HLA-B27 transgenic rats, it's a rat model of SPA, if you keep them in the absence of any bacteria, the rats are perfectly healthy. If you recolonize them, they develop disease. So that's a classical example of that. There are other examples, but there are also examples where microbes may be not that important. Okay, so it's not a black-white answer. And to study that, what people have been doing is to look at the sequencing of bacteria. So nowadays you can actually sequence these bacteria. You can do this in biopsies, as we have shown here, but you can also do this in stool. I will not bore you with going to all these data, but I try to come up with some concepts. So one of the concepts here is that if you look, for example, in the biopsies of patients with SPA, you look here in the terminal ileum and the colon, what we found is a certain family of bacteria called Dialister, which had been linked to tooth infections being more abundant when you have gut inflammation. This now been replicated by several studies. Now, the important message also is, if you look to this in bacteria, it's not a single bacteria. So there are shifts in bacteria, which we call dysbiosis. Unfortunately, the font of this slide is a bit slower, is too small, but there were a number of studies by José Cher, for example, Maxime Bréban. Our study also is in there. But you see, for example, a bug which is coming quite back often is called Ruminococcus flavus. Okay, you have Dialister, Ruminococcus flavus, and there are others. And I'll try to come up with some conclusions on that. So in other words, there are shifts in bacteria, and that's an association. So we see that more in patients than controls. The interesting thing is that some of these bacteria may be linked to disease activity. I'm giving you the example of the Dialister, but the same holds on for Ruminococcus. So what you can see on this slide, the more Dialister you find in the intestine, the higher the ASDAS, and as you know, that's a disease activity. Okay, so still, this could mean that that you have more D. alister because you have a higher disease activity. So this doesn't prove that the bacteria are really cause or consequence of the disease. If you want to study that, you need to do fancy experiments. And some of these experiments are done in our institute using germ-free mice or gnotobiotic mouse facility. And what you do here, you see this is a high-tech environment where here the mice are being bred in absence of bacteria, and you have to work through these gloves to manipulate these mice. And this is headed by Lars Verreke, a colleague of mine. And so the types of experiments that we do is we put bugs into germ-free mice, or we put cocktails, or we do transplantation of stools, and that's actually ongoing work. And here, this is Lars Verreke, and for clarity, this is of course not stool, but this is from a chocolate workshop that we did with Belgian chocolates. And the types of experiments we're doing is we are taking patient samples from patients that have high amount of D. alister versus low amount. We put them into mice and we see what's happening on the phenotype. That's the type of experiments to really prove that this is doing something in a mechanistic way, but that's ongoing work. So, so what is then the link with the immune system? And so, there's a lot of study there. I will just give you one example of that. We know a classical example is that the bacteria in the intestine, some of them may make certain products, which, for example, a classical example is short chain fatty acids. They work, for example, on making the barrier on the intestinal epithelial cells more tight to one another. But on the other hand, they also have an important effect on the immune system. And especially the regulatory T cells that actually suppress autoimmunity are the ones that are being influenced. And this is the original paper that showed that certain bacteria, and the name is not important, it's now Clostridia cluster 4, but that the name is not important, but there are bacteria that make butyrate, and they do this much more than others. And you can see that if you, for example, take these bacteria and you put them in a mice versus other type of bacteria, you see that this bar is much higher than the other bacteria, okay? So they make up to 40% regulatory T cells. So in other words, the bacteria in the intestine actually boost suppression of inflammation by boosting the regulatory cells. And the interesting thing is that some of these bacteria are being reduced. They are being reduced with Crohn's disease or diverticulitis, also in spondyloarthritis. There's less of them. So that means that the immune regulation is also dampened. Okay. There's an additional element there. Is if you see what the consequence of that is, for example, in a mouse model. So this is, for example, a mouse model where you have Crohn, you have arthritis, and you have spondylitis. And you can see nicely that this mouse model that's TNF dependent has spondylitis. So this is a PET scan in a mouse where you have the swelling of the bowels, but you also have the hunched back, you have intestinal inflammation, and you have a spondylitis, okay? And so one of the things that we try to understand is why do these mice develop inflammation despite that these mechanisms of immune regulation should be operating, okay? And to do that, also you see here the video, the mouse is turning, and you can nicely see the hunched back with the spondylitis, okay? So the bottom line of this is that even though you have these immune regulatory cells, when you think about spondyloarthritis, it seems that these cells are functionally not doing what they are supposed to do. Okay, so what you see here is these are suppression cells. So what they normally do is they suppress cytokine production. So in other words, to keep the inflammation down. But if you compare the wild type versus the spondyloarthritis mice, you see that these Treg cells are not doing that well. So even though you have the microbes and they're making the short chain fatty acids, etc., they are not sufficient, in fact, to suppress the inflammation. Eventually, what the consequence of that is that you cannot control the inflammation and you actually have a chronic disease. That's what we are dealing with. And in reality, this is a much broader field. So it's not only Treg cells, there are these other specialized immune cells that also play a role. And this all leads to this balance that shifted, leading to inflammation and disc joint access. So do we know, in fact, a key question, when we think microbes are important? Okay, and the reason why I'm saying that is that during our life, when we get born, birth is an important aspect when you get exposed to microbes for the first time, whether it's cesarean section or whether it's conventional delivery. The breastfeeding is an important thing, and of course in adult life. And what we see is we reported that these microbes change quite drastically in these phases. Now, one key question that is the microbes important early in life or is it in adult life? And this was indirectly addressed by the protective effect of breastfeeding. So breastfeeding is an interesting feature because it might protect the children from later on developing diseases. And in fact, without going into the details of this table, but what this study several years from Maxime Breban showed is that it may be that people with SPA have less breastfeeding than controls. I haven't seen this independently replicated, but the concept is interesting, right? So if you would have less breastfeeding, you would be more at risk to develop later on that SPA. And that may be linked to the microbiota. In fact, we know that if you modulate the intestinal immune system early on in life, this has consequences in adult life. And there are several models. So there are certain bacteria that we are capable of actually, when they are colonizing the intestine early in life, to actually really have an impact later on in life. We've shown this in a report several years ago. And this would lead to a situation where we think this is a unidirectional model. You have one bacteria coming in, it colonizes the intestine and it causes a disease phenotype. Unfortunately, I think in reality, it's much more complex. So it's probably a mixture of things where genetics plays a role, where the immune system plays a role, and this may depend on the disease. And that's where we think a multidirectional model. But the interesting element is that in the entire lifespan, these microbes may be important, but remember as a take-home message that perhaps even what we do or what we experience in childhood may determine our risk in adulthood. I'd like to end with therapeutic perspectives and also some caveats. There's a lot of drugs available in microbiome-based therapeutics. On the one hand, of course, the diets, there are probiotics, there is the fecal microbial transplant, and there are conventional drugs. I think something I hope is new to you, but for example, the checkpoint inhibition that's been revolutionizing the field of cancer immunotherapy, the success rate of that is linked to your microbial composition. This was originally described in Science about 3 years ago. And I'm sorry, this is a busy slide, but for example, if you look to this middle panel, it's comparing the survival rate of patients that got antibiotics prior to the checkpoint inhibition versus the ones that did not have antibiotics. So no antibiotics versus the ones that had antibiotics prior to the checkpoint inhibition. You see a significant effect. And to make a long story short, it's linked to microbes in the intestine. Certain types of bacteria do this more than others, and they actually are important in shaping the immune response to the checkpoint inhibition. This has now been confirmed for all kinds of checkpoint inhibition. So in other words, the concept is there that the microbial composition is determining the response to immune therapy. Okay, and that's in cancer immunotherapy quite strong. What about rheumatology? I think José Cher has done some elegant pioneering work on this regard. He has shown some shifts in concept with cytokine inhibition. So there is also something cooking there in terms of therapy responses potentially with biologics. But most recently, he has been interested in what is the impact of microbes on the conventional DMARDs. And for example, we almost forgot that we have metabolization of certain drugs, and microbes may play a role into that. We know that for sulfasalazine, of course, that you have the activation of a prodrug into active drugs. But for example, biotransformation into inactive drugs metabolize may be the case for methotrexate, I showed it, or sometimes even into enterotoxic metabolites, okay? And bacteria play a role in that. And without going into much detail, he has just published a paper in rheumatoid arthritis where he showed that if you respond to methotrexate versus non-responders, so here are the responders versus the non-responders, in essence, what the message of this slide is that yes, there is a big difference in the microbiota composition at baseline, and it predicts actually the outcome with a true negative rate of about 83% and true positive rates about 78%. Is it perfect yet? No, but it's an interesting idea that the microbial composition is determining your long-term outcome. If I may, Philip, I'd like to end with some things that have recently been published. We know bugs for drugs is a hot item. Can we generate new probiotics? What is the role of fecal microbial transplantation? Or do we have alternative strategies? So there is a tendency to also go into, let's say, synthetic microbes composition. We call them microbial ecosystem. So what you do is actually you plug and play and you come up with a synthetic microbiota. It sounds a bit artificial. You put this in a pill. There are a number of companies that are active in the space. And one of the companies actually announces this for Clostridium difficile. Remember, the biggest success so far in fecal microbial transplantation has been in Clostridium difficile. And if you were an investor and you had chosen this company, the moment they announced that, you would be a multimillionaire, because this is what happens with the announcement of this, that the stock actually almost exploded. But the idea is basically we are evolving into newer types of therapies. Because we know fecal microbial transplantation is a bit a dodgy type of procedure. It's perhaps interesting as a proof of concept. You have also this standardization of the stool that you need to do, and there are some side effects. For example, one of the things is the weight gain that have been reported by some recipients of stool transplant. But I wanted also to close with the results of the fecal microbial transplantation study in psoriatic arthritis. So there was this year a study reported in Annals of Rheumatic Diseases, which did actually the randomized placebo-controlled trial, one dose of fecal microbial transplantation versus sham operation, and the 26-week procedure. The shocking thing is that from what their primary endpoint was failure or a failure of sustained therapy, so therapy escalation. And the surprising thing was that that actually the patient that received the transplant seemed to do worse than the sham. But there are quite some caveats and maybe. So is it really a failure? And so here you see the treatment failure from the sham versus the fecal microbial transplantation and then the HAG-DI. But there are still a number of important things. So the baseline microbiota analysis was lacking. The endpoint is actually not really a validated endpoint. We don't know much about the donor selection for the fecal microbial transplant. That's super important because some healthy donors are what are called super donor. We don't really know whether we are talking about super donors here. Patient selection, these are actually patients with polyarticular disease, refractory disease. There was a really surprising placebo response with high rates of ACR 50 and 70 in the placebo. And interestingly, most of these patients were on methotrexate. And we have no idea when you give a fecal microbial transplantation to somebody on the methotrexate, whether that changes, in view of what Gottscher reported, changes the production of, for example, the bioavailability of methotrexate. So lots of questions, but the essence is it's a failed trial. So conclusions, I hope I've convinced you this is a fascinating area of research. Oops, sorry. Can I go back one? Well, let me go. I hope I've convinced you it's a fascinating area of research. There's something there with microbes. There's still a lot of to learn. And hopefully, this can translate into therapies. If I can, 2 seconds to finish with something funny. There is, for the people that are a bit older like I am, if you treat fish with young poo, old fish with young poo, it turns out that the old fish becomes younger. Okay, so there's something with bacteria, and this thingy is blocked here. I don't know what's happening. Okay, so for the people that have babies already or grandparents, don't be shy, I would say, to change the diapers. And we are trying to study that in worms. And so what we did here is we work on a certain peptide that's coming from bacteria. And I show you the video. You see here the worms, C. elegans, it's moving. And the surprising thing is that if you treat these worms with one certain peptide that's coming from bacteria that we also see in people with sarcopenia, you see that the worm is actually slowing down. Right? So in other words, there is really something there, and it's really a field that's eye-opening. So I hope in the future I'll come and be able to tell you the entire story on this one. I stopped there. I was probably a bit over time. I hope I've also made you some type of excitement about this field, and happy to take questions.
Thank you very much, Dirk. Wonderful talk. For people who've just had their lunch and they're generating some fecal microbial activity, it's food for thought. But just one question has come through, and that's to do with your diet. And clearly our fecal microbiome is fairly fixed from an early stage, but can we change it with what we eat?
Yeah, so I think that's a really good point. So we know, of course, that there are a number of things that have been done. The challenge, I think, is with diet is to do diet interventions in a controlled way with very good, reliable data. So we know if you do trials with diet, you have about a 50% non-compliance. Okay, that's a bit the challenge. That being said, we know, for example, vegetables, high fiber is important because they are a source, for example, of short chain fatty acids. We know, for example, and this study, I didn't touch on the study of the Ramadan, and that people actually went into remission, which is very interesting, I think, because it suggests that that's really a link between nutritional intake and disease activity. The problem is to do this in a really controlled fashion is, I think, is a bit of a challenge. So what people from the Erlangen group have tried to do is to collaborate with the bakery. It's kind of an interesting study. So what they did is they provided some kind of food bar with very rich in fiber. And then it's an open trial, it's absolutely not controlled, etc. But then they looked at immune responses and they saw actually some shifts in rheumatoid arthritis. So yeah, I'm a strong believer there's something there. Is it solely sufficient to have everything under control? I would doubt it. Is it an element that's important? I think yes. But we need to do actually the really hard endpoints. And to come, for example, the fecal microbial transplant trial, there was a huge dropout in this patient. The screening failure was high. So, yeah, and it's a single type of administration, etc. So, yeah, I think there's more stuff to do.
Yeah, I read that and felt the same way, but that's absolutely great. And it's clear that this aspect of our disease and science is still at a formative stage. And as you say, maybe a few years' time, we'll get you back to give us all the answers.
Right.
Hopefully. So thank you for that. We won't see you at the Q&A, but thank you for your contribution to the meeting, and have a good rest of the day.
All right. Okay. Thank you, everybody. And hopefully you enjoy the rest of the meeting, and looking forward to see you in person again soon. Thank you. Bye-bye.
Thank you, Dirk. Bye. So it's now my pleasure to introduce Dr. Miriam Wittmann, who works with me in Leeds and Bradford. And Dr. Wittmann is an associate professor at Leeds University. She has a particular interest in cytokines, but I'm glad to say for the last few years, she and I have been doing a combined clinic in Bradford, and I'm going to share my slides. If I can get this up. And just go through these with you. And Dr. Wittmann is on the line there, is going to join me. So if you'd like to say hello, Miriam. Perhaps you're muted.
Yes, hello, everybody. Can you hear me okay?
We can hear you, thank you. So as I said, Dr. Wittmann and I have been doing a combined dermatology rheumatology clinic for some time in Bradford. And what we do is run the service as together rather than in parallel or remotely. So we see patients physically together, 2 consultants, 1 patient. So the objectives of our talk are to describe the need for joint psoriasis and psoriatic arthritis clinics, to discuss how the clinics can be established and set up, and insights and lessons learned from our particular experience in Bradford. So the advantages of a joint service for the patient, of course, is probably paramount. There's less visits, more efficient visits because they're getting 2 opinions at once, and it generally improves patient care and certainly patient satisfaction. For the doctors, we get insight into decision-making from the other discipline, and each of us learns how to assess from our own perspective. So I learn more about assessing the skin, and Dr. Wittmann learns more about assessing the joints. We're able to discuss difficult cases together and see the more complex cases together. But such clinics have a very important role in education, particularly from medics in training and nurses in training. It's a great opportunity to learn and generally have more time with the patient, so there's more discussion available. And of course, there are opportunities for research, very importantly. And here we are in one of our clinics, Dr. Wittmann and myself, looking at an X-ray with a specialist nurse in attendance. And these clinics are generally very satisfactory and very rewarding to do because of the interdisciplinary cooperation and as I said, primarily from the patient's point of view. So you work as a team, of course, and it gives you more insights into interdisciplinary collaboration. It fits in with our educational aims. It empowers staff and the patients and allows us to achieve and access more effective therapeutic pathways, because there are some drugs licensed for skin and some for joints, and we can, as it were, get leverage into those particular pathways. And as I've mentioned before, research is of paramount interest, and Dr. Wittmann will discuss that in more detail in a minute. So I'll pass over to Miriam now, just to discuss some more aspects of this joint clinic.
Yeah, thank you, Philip. So this slide shows you just some of our own impressions, our own feedback, how management may have changed when we together in the combined clinic, facing people who have both psoriasis and psoriatic arthritis to different disease activities. And so there are some of the therapeutics each discipline uses, which are not necessarily helpful for the other condition. And I'm specifically mentioning acetylene here, which I probably use in general less than I used to do for psoriasis patient only, and in particular in the combined clinic. This is often not really an option for the holistic treatment of a patient. On the other hand, I sometimes remind Philip that we also have phototherapy as an option. If somebody has a breakthrough with a flare, which has an exogenous trigger, you sometimes can adding in phototherapy can in some cases be beneficial. And this is something rheumatologists may not think of. In general, with the biologics, I think we try to stick a little bit more to TNF inhibitors than I would perhaps do in a fully dermatology clinic. But obviously, this is the discussion we have in each case. And in general, with comorbidities, especially from the dermatology point of view, we have situations where we are grateful for licensing of JAK inhibitors in rheumatology, which we cannot prescribe for psoriasis only, in particular when patients have alopecia areata, vitiligo, as well as psoriasis. And then obviously hidradenitis suppurativa is also treated with TNF inhibitors, and that can influence our decision. So as from a dermatology point of view, I think my biggest learning, apart from learning about psoriatic arthritis itself, is also to learn more about pain management and the difference between inflammatory arthritis and fibromyalgia, and how they may present differently, etc. So these are just some thoughts. I'm sure there's much more, but I think both disciplines can benefit doing a combined clinic together. And obviously this immediately impacts on how the patient care. In the next couple of slides, I would like to share with you some research which was actually also triggered by the combined clinic. So the scenario we often have is that we have somebody with inflammatory arthritis where it's not absolutely clear whether this really is psoriatic arthritis. And these people may present with only minimal skin involvement, or skin involvement which is in locations where we don't really like to do diagnostic biopsies. And we thought it would be really great to have an easier diagnostic approach to skin lesions which are difficult to biopsy or minimal in their appearance, and you can't immediately do the diagnosis of psoriasis. And it was also influenced by the fact that we see quite a few people with palmoplantar lesions where we can't immediately decide, is this eczema or is this psoriasis? And sometimes the histopathology is also not very clear, because they sometimes talk about psoriasis from eczema or eczematized psoriasis. So this is where we're coming from. And in the next slide, you can see the approach we've chosen. And this is to take tapes. So basically you harvest some of the scales, some of the superficial scales from the skin, and we do this from lesion and non-lesion. And you can see in this optical coherence tomography picture, which is basically a type of ultrasound, that we really don't go very deep into the skin, but it's really only a very surface sample. We then proceed to extract protein and measure this. And you can see in the next slide that we initially looked for a great number of inflammatory mediators, and not all of them are abundantly in the tapes, but there are enough in the tape to give us an amazing result, which I will share in the next slide. So we found specific markers in these scaly protein samples for psoriasis, which are not up to the same degree in eczema lesions. And as you can see on the left-hand side, IL-36 gamma, which is a molecule from the IL-1 family. No, sorry, Philip, can you go back again? IL-36 gamma is really highly expressed in these samples in psoriasis, but not so much in atopic dermatitis and not in healthy. And I want to draw your attention on the cutoff. So anything above 214 picogram IL-36 per microgram total protein is psoriasis. And then we found a second one, elephine, which is also seemed to be also a very good marker in these sample types. So next slide, please. On the next slide is an example of
sorry, it's oh, here we
are. Of somebody we initially recruited into a hand eczema study. And at some point during so it was a longer follow-up period. During the follow-up period, our attention was on nail changes. And actually this patient presented with pitting. And also the phenotypes, the morphology changed a little bit. So we proceeded to do a diagnostic biopsy in this case, but also did the tapes. And as you can see, the IL-36 gamma is way beyond the cutoff limit of 214 picograms.
Sorry,
so that the conclusion both of the diagnostic biopsy and the tape was that indeed this patient didn't have hand eczema, but hand psoriasis. And the next example is a patient who actually came from rheumatology. So Philip asked me, is this psoriasis? If it's psoriasis, this patient may have psoriatic arthritis. And we did the same approach of this lesion in the ankle area. And as you can see, the cutoff of the IL-36 was below 214. So we said, sorry, but this is eczema. It's not psoriasis, it's chronic eczema. And that was actually confirmed also in a diagnostic biopsy. And yeah, so in summary, we think we have a really good non-invasive approach to diagnose in minimal diseases or in difficult areas, whether we're dealing with skin psoriasis or not. And we continue working on this as a diagnostic tool. So the next one, Philip?
I think it's mine.
So I hand back over to Philip, and this was just an example to show you how a combined clinic and the discussions we have and the problems we face can inspire research and let us to ask the correct research questions relevant for both of our disciplines. All right.
Thank you, Miriam. Yeah, and I think the audience will have seen this slide yesterday from Laura Savage, which shows the rheumatologist's role on the right and the dermatologist on the left. Clearly, the rheumatologist's role is to confirm the presence of inflammatory arthritis in people with psoriasis. And as we've just heard, the dermatologist's role is to confirm the presence of psoriasis where there's doubt about that. And in Leeds, where they run a sort of parallel clinic, they have an opportunity to knock on each other's doors when they have a question. And surprisingly to me, most of the traffic was from rheumatology to dermatology. Come and have a look at this rash, rather than dermatology to rheumatology. I've got a patient with joint pain, what's causing it? So most of it was the rheumatologists having queries about the rash. So we have joint functions, of course. We monitor compliance and adverse events, and we screen for comorbidities of all our patients. And one thing as rheumatologists we do badly, particularly our patients who've had light treatment and are now on biologics, is to screen for skin cancer. And that's one of the important roles. And of course, to do that, you've got to get the patient's clothes off. And it's something we don't often do in rheumatology. And I've learned that from my experience working in a joint clinic, that the patient takes their clothes off if you're going to get anywhere and examining their skin and, of course, their joints thoroughly. And as we've already discussed, there are a number of models. You don't have to work in the same room. Although I think that's a very rewarding way to do it and gives high patient satisfaction. But you can work in parallel, as I've just described, as they do in Leeds, down the corridor in rooms adjacent, so that interruptions can be made for a quick review. But you can do it virtually as well. If your dermatologists are working in a different hospital or some remote location, you know, you've all got phones, you've all got cameras on your phones. Particularly for rheumatologists, you can take a quick picture and send that. It's a bit more difficult for the dermatologist to do, but you could certainly ease consultation that way. So in this brief presentation, it's necessarily brief because we're a little bit behind time, but I hope that Dr. Wittmann and I have given you some pointers as to why it's important and the benefits of doing combined working, interdisciplinary working, particularly between rheumatology and dermatology. Of course, there are other interdisciplinary roles as well. For instance, we do a combined clinic with the gastroenterologist and the ophthalmologist because of these important comorbidities. And of course, orthopedic surgeon and combined clinics have been running for many years. For the patient point of view, it provides a better outcome for them because they get their problems sorted in one go rather than several goes. And there's no question or problem with misinterpretation or contradiction between the two specialties if you're working together. And we see the more complex cases, of course, we think it saves time and money, although that's yet to be proven, but it certainly improves patient satisfaction. I'm going to stop screen sharing now. If you've any questions on this, well, we'll take the questions in about 15, 20 minutes time. So if you could hang around, Miriam, that would be great. Thank you very much. So it's now time to introduce Professor Louis Puig. I hope Louis is there. Dr. Puig, or Professor Puig, is a professor of dermatology in Barcelona. I know he's a great football fan as well. He works at the Hospital de la Santa Cruz et Santa Pau and has got a vast experience in the field of psoriasis and is frequently talks at national and international meetings.
Thank you very much.
I'd like to give the floor to you now, Luis.
Thank you very much. It's my pleasure to participate in this symposium, Grappa symposium, and I would like to talk on comorbidities in psoriasis and psoriatic arthritis. And I would like to start by somehow describing this complex constellation that demonstrates the commonality in terms of pathophysiology and genetics between psoriasis, psoriatic arthritis, inflammatory bowel disease, and uveitis. And in my view, this is the most important driver of comorbidities in some of these in some patients. And because of this association, we can talk about psoriatic disease. And then systemic inflammation, but mostly on the fact that especially obesity leads to metabolic syndrome and its complications, such as dyslipidemia, fatty liver, hypertension, diabetes. All the components of metabolic syndrome can be also associated to kidney alterations and are the main drivers of cardiovascular disease and chronic obstructive pulmonary disease. And I would like to comment that there are some other kinds of comorbidities which are more related to the psychological complications or perhaps consequences of having severe psoriasis. These are depression, anxiety, and stress, which might lead to alcohol abuse, smoking, addictive behaviors. And in some cases, these comorbidities might interact. So for instance, obesity together with stress or anxiety might lead to sleep disorders. Depression together with diabetes mellitus might lead to sexual dysfunction. And finally, I would like to comment that as regards malignancy, which is also recognized to be increased in risk in patients with psoriasis. In part, this might be due to previous treatments, but to a large extent, this depends on these habits or life characteristics of patients with psoriasis who are very prone to alcohol abuse and smoking. And this leads to lung malignancies and also bladder malignancies and lymphomas. And this somehow inflammation might have a role in the development of this of cancer, because cancer is also an inflammatory disease. Talking about the cognitive side of psoriasis, we already covered this one. We know about the hazard ratios for all these comorbidities that range from from 3 to 1.5, depending on what we are talking, but mostly obesity and metabolic syndrome are 50% more likely to appear in patients with psoriasis. And as a matter of fact, they precede the development of psoriasis. Inflammatory bowel disease has been observed in 2.5 5 times the the ratings, the general population. And of course, we all know about the psoriatic arthritis and its different phenotypes, which can, as a matter of fact, appear in up to 40% of our patients. So 20% of our patients with psoriasis can be diagnosed as having psoriatic arthritis. Talking about psoriatic arthritis, it is quite interesting to see that the prevalence of all these comorbidities in psoriatic arthritis is higher than that in patients with psoriasis without psoriatic arthritis. And this might be due to several factors, and perhaps the most important factor might be that the systemic inflammation in psoriatic arthritis measured by CRP or interleukin-6 or any other biomarker of inflammation is higher than in psoriasis. So skin inflammation can become generalized or systematic, but systemic inflammation is much more commonplace in patients with psoriatic arthritis. And this can also be applied to some of the germane spondyloarthritis, which are the remit of Grappa. So axial spondyloarthritis have also been investigated in terms of increased risk of comorbidities. And you can see here two very nice systematic and meta-analysis estimates that can apply to your practice. I would like to just touch a little bit on the impact of the patient's comorbidities as regards the choice of treatment. And we all know that several drugs that we are using in psoriasis and even in psoriatic arthritis, such as methotrexate, of course, can have some contraindications, but also might increase or worsen or have an impact on some comorbidities, such as fatty liver, for instance. They're prone to lead to drug interactions, and they might cause hypertension or diabetes or worsen them, as is the case with cyclosporine. On the other hand, most of the biologic agents which we have become used to apply in the treatment of our patients with psoriasis are associated, have a very clean profile in terms of the comorbidities of the patients, and only some issues about the heart failure, for instance, with tumor necrosis alpha inhibitors, or about the risk of worsening inflammatory bowel disease in some patients treated with IL-17 antagonists must be taken into account. I would like to start remembering the history of the recognition of cardiovascular disease in associations with psoriasis. And this comes from a paper published 15 years ago that demonstrated an increase in the risk of myocardial infarctions in patients with psoriasis. This risk was higher in patients with severe psoriasis, defined by the use of systemic treatments, but was the relative risk was much higher in especially in young women, as compared to elderly patients. It tended to decrease in patients who above 70 years. It is important to remember this, but also it is important to take into account that numerically, even though the relative risk is lower, the impact of psoriasis or psoriatic arthritis in other studies as regards myocardial infarction is much higher. Numerically, the size of this effect is higher in patients on their middle ages. And this is interesting that since myocardial infarction might occur in younger patients, to some extent, perhaps this might explain the better prognosis of those patients that has been found in terms of a lower hospital mortality rate in a very recent study. There's a systematic review and meta-analysis that confirms this higher relative risk of cardiovascular disease in patients with psoriasis, which is highest in younger patients and with those with severe psoriasis. But it must be highlighted that the most studies have failed to adequately adjust for key traditional risk factors. And when we do this, and this is a very interesting study that was published 6 years ago from the data link database from United Kingdom, it was shown that neither psoriasis nor severe psoriasis were associated to short to medium term risk of major cardiovascular events after adjusting for known cardiovascular disease risk factors. But when we included inflammatory arthritis, of course, diabetes, chronic kidney disease, and hypertension, but only when we included inflammatory arthritis, that is, patients with psoriatic arthritis, did an increased risk appear. This is highly relevant for your practice. And usually we must take into account that we use the score or some other ways to determine the risk of death or due to cardiovascular disease, and this has therapeutic implications. Age is, of course, the strongest risk for fatal cardiovascular disease, but some other factors must be taken into account. They depend on countries, but it has been accepted that in patients with, for instance, rheumatoid arthritis, it is important to multiply the risk factor that we calculate based on these algorithms or tables by a factor of 1.5. And it is important to take into account that in psoriatic arthritis, this should also apply, and perhaps in psoriasis. And what's the consequence of this multiplication? That we should start using high intensity or moderate intensity statin therapy. This intensity, this is as a matter of fact just prescribing a standard atorvastatin pill, which should be done in 60% of our patients. So please take this into consideration. You can contribute to reduce the risk of cardiovascular disease in our patients, because it has been demonstrated that after 18 months of treatment with, for instance, rosuvastatin, the risk of cardiovascular disease decreases, and it has been shown that keratic plaques regress. So there's an improvement in arterial stiffness and blood pressure by using this anti-inflammatory statin. That's important. We will discuss that a bit later on. There's a well-known relationship between obesity and psoriasis. It seems to precede the development of psoriasis and also psoriatic arthritis. You'll know that trauma is an important factor. Trauma and stress, mechanical stress, is obesity contributes to that in the development of psoriatic arthritis and spondyloarthritis. But it has been shown quite recently that there's a causal relationship. So it is the increasing body mass index that leads to the appearance of psoriasis and also to psoriatic arthritis. And there have been many studies that have been analyzed the fact that the impact of different adipokines in this in the disease, but they have shown they are plagued by the great variability because they depend on sex, age, on many factors. It might be that the most important role is that of adiponectin, with a decreased serum levels of adiponectin in our patients, which predisposes them to visceral obesity and also to metabolic syndrome. This is quite well known. This psoriatic march that highlights the role of insulin resistance and endothelial dysfunction in our patients, and it is important to consider that there seems to be a low-grade systemic inflammation that happens in psoriasis, but not just in psoriasis. Perhaps the main drivers might be fatty liver or hypertension or some other factors. But as a matter of fact, all the cytokines which we know are relevant in psoriasis and in psoriatic arthritis are also important in driving inflammation in some other organs and leading to the comorbidities such as non-alcoholic fatty liver disease, cardiovascular diseases, diabetes mellitus, or inflammatory bowel disease. It is important to consider if this systemic inflammation, which can be measured by a surrogate by CRP or by some other measures of systemic inflammation, comes from circulating T cells or some other cells, or is it the skin inflammation that somehow overflows to the circulation and leads to this effect? And it might be adipokines, of course, but it might be also the interleukin, the well-known interleukins and cytokines that we all are quite aware of. Perhaps they can leave the skin, leave the fat, and have an effect distally. Perhaps the cells might be circulating and have their effect. So this is important because, for instance, just with talking about interleukin 17A, depending on the context, they might, interleukin 17A and other isoforms of interleukin 17 might have both harmful and also beneficial role as regards the evolution of the plaques of atherosclerosis. You all know that stable plaques do not represent a risk for cardiovascular disease, whereas the inflamed and unstable plaques are the ones which carry this risk. So calcified plaques can be considered to be a factor of good prognosis. We will discuss that. So there's some evidence that the inflammation in psoriasis becomes systemic, but we don't know really which are the cytokines which drive this inflammation. It might be tumor necrosis factor alpha. It might be interferon type 1 released by the activation of plasmacytoid dendritic cells by, for instance, interleukin 36 receptor activation. There's a lot of knowledge to be learned. We know that psoriasis is associated with increased vascular or systemic inflammation, and we learned this initially from fluorodeoxyglucose PET scans. This nowadays has been somehow superseded. There might be better ways to provide the imaging of this inflammation, especially the atherosclerosis in the big vessels. But it is well known that based on these studies, visceral adiposity in psoriasis beyond cardiometabolic disease risk factors is associated with vascular inflammation. So it might be, on one hand, the severity of the disease, the PASI, or the severity of the psoriatic arthritis that we will discuss, but to a large extent, it's the visceral adiposity, the degree of metabolic syndrome that is associated with this inflammation. Psoriasis severity, of course, independent of cardiovascular risk factors, is associated with vascular inflammation. So this implies that psoriasis has a systemic inflammation component beyond the impact of metabolic syndrome, which can be associated with psoriasis. And the same applies to psoriatic arthritis. So we know that subclinical atherosclerosis is commonplace in psoriasis. It can be measured with angiography TC scans. And we know now that the plaque burden in psoriatic arthritis too is also independent of metabolic syndrome and associated with underlying disease severity. So patients with psoriatic arthritis, regardless of their having metabolic syndrome or not, have similar plaque burdens and types. And then, of course, there are some other independent predictors of plaque burden in psoriatic arthritis: the severity of the disease, the C-reactive protein levels, the disease duration, and also the presence of diabetes mellitus, or the levels of glucose. So what is are there any ways in which we can provide primordial prevention to patients without any cardiovascular event before it becomes apparent by imaging, for instance? Well, there are some data in that respect. Now we know that the risk of psoriasis is linear. It's very similar to that of low density lipoproteins. There's no threshold or cutoff value. Any degree of psoriasis increases the risk of cardiovascular disease due to atherosclerosis. And there are many patients without increased risk scores who do have atherosclerosis, as measured either by ultrasound of the femoral artery or by coronary computed tomography angiography. Very interesting studies that show again that some factors which are the main determinants of this subclinical atherosclerosis in patients who otherwise have a low risk score. These are hypertension or the presence of insulin resistance. And this, the presence of subclinical atherosclerosis again calls for action, calls for intervention, and for the treatment with statins. What is the effect of psoriasis treatment on subclinical atherosclerosis? So there are many complications in that respect. Is there any systemic effect of any treatment? We have data from epidemiological studies. We have data from this kind of functional studies. We don't have hard data based on follow-up of patients for a long term, trying to assess if they decrease the risk of cardiovascular disease, of heart attacks or myocardial infarction. But we can measure these heart outcomes, but we can also measure some physiological markers, or we can image vascular inflammation or the morphology of coronary atherosclerotic plaques. And I will just discuss that based on epidemiological studies, tumor necrosis factor inhibitors can have been associated with a decrease in the incidence of myocardial infarction. and that's based on a 10-ish cohort. And the effect of TNF alpha inhibitors on cardiovascular events in both psoriasis and psoriatic arthritis have been highlighted by an updated meta-analysis that shows that the TNF alpha inhibitors have been linked to a reduced incidence of myocardial infarction when we compare them with a topical or phototherapy or even methotrexate treatment, which was initially purported to have some protective effect. The effects of psoriasis intervention with biologicals has been widely studied. There are many anecdotes and there's some evidence. And the most interesting studies of the effect of all these biological agents have focused on adalimumab, on ustekinumab and secukinumab. And it is interesting to see that even though there are some reductions in some inflammatory markers, only for ustekinumab, an early reduction on the imaging of inflammation has been demonstrated early on at week 12, but has become not apparent at week 24. So based on these studies, even when there's an improvement in this captation of 16-fluorodeoxyglucose, the early on effect of ustekinumab on this captation, on this inflammation, is similar to the effect of statin. So perhaps we should not be trusting so much the impact of our biologic treatments, but we should be treating more aggressively our patients with statins. There is an association between the inflammation on the aorta and, of course, the plaque characteristics of the coronary arteries in psoriasis. And this is why most of the current studies from the NIH and other centers have focused on the non-calcified coronary plaque and the potential improvement in this plaque morphology. And now we know that the biologic therapy has been associated with a significant 6% reduction in the non-calcified plaque burden. Let's remember that calcified plaques are okay. Non-calcified plaques are those which are prone to rupture and to cause myocardial infarction. And this improvement associated with biological treatment is persists beyond adjustment for the traditional cardiovascular risk factors. So we can tell our patients that with our treatment, we can decrease, we can improve their coronary artery atherosclerosis. And this applies to treatment of psoriasis with biologic therapy. We don't know yet if this applies to treatment of psoriatic arthritis, and a lot of research must be done in that respect. I will just finalize this presentation with just a reminder of the high prevalence of fatty liver in psoriasis, also to some extent in psoriatic arthritis, because patients with psoriatic arthritis, like patients with psoriasis, but not like patients with rheumatoid arthritis, have a high body mass index, and this is the driver of fatty liver, which eventually progresses to steatohepatitis and eventually to cirrhosis. And there's a lot of research being made on which are the drivers, the cytokines that drive this transformation. And it seems that interleukin 17A can be very important in that respect, but perhaps also through necrosis factor alpha. This is a summary of the studies that show this increase in the risk of liver disease in patients with psoriasis or psoriatic arthritis, which is even higher in terms of than that of patients with rheumatoid arthritis and some other rheumatological disease. And we know that the risk of liver disease in patients with psoriasis is higher than that of patients with psoriatic arthritis, but especially higher than that of patients with rheumatoid arthritis receiving methotrexate. So those of you who are rheumatologists and care for patients with rheumatoid arthritis and give them methotrexate must remember that the methotrexate can be more harmful, or at least a higher concern should be taken for patients with psoriatic arthritis. There are several ways in which we can suspect and screen fatty liver and non-alcoholic fatty liver disease. And the most important of them are fibrosis scores, which provide a calculus of the probability, and then imaging studies, mostly FibroScan and some other techniques. And these should be used and applied in our practice. And we are doing them, for instance, using the FIB4 calculator or the fatty liver fibrosis score for all our patients whom we have treated for a long time. And finally, there's a clear-cut demonstration of the significant association of psoriasis with inflammatory bowel disease, especially with Crohn's disease. And this applies even more to patients with axial psoriatic arthritis, and even more, of course, to patients with spondyloarthropathies. And of course, this has implications as regards our choice of treatment, because when we choose to use an anti-IL-17 agent, we must have a special concern about the potential development of gastrointestinal manifestations, and ruling out with calprotectin or whatever terminations the appearance of the trigger of inflammatory bowel disease, especially if the patient has family relatives with this condition. And this closes my presentation. There are some very nice or very complex references that show the way in which we can act in our patients with different comorbidities in order to provide a comprehensive and holistic care to our patients. Thank you very much. Now there are there were several questions. I don't know if they should be presented right now or later on, or they should what can be done with them. Thank you very much.
Thank you very much, Luis. Wonderful presentation, very comprehensive. We're going to transition to the Q&A now. So if you hang around, there's a little delay before we all get on screen. I think we're nearly there.
Anything from the attendees here? Anybody has a question? You want to come up to the mic, please? So we have a question from here, Philip.
Okay, we have some live people there. Wonderful.
Yes. Hello, this is Dr. Yusra Suleiman, specialist traumatologist. My question is to Dr. Miriam. My question is that we as rheumatologists face the challenge of the diagnosis of psoriasis on its own. So sometimes you get from the history patients with skin disease that happened long ago, or scalp disease that is diagnosed as like seborrheic dermatitis, or skin disease diagnosed as eczema. But then this, like the patient got treated and this went away. But the patient came to you with polyarthritis that's still early, that you cannot, that's a rheumatoid factor, CCP negative, ANA negative, all the autoimmune markers are negative. So we're still in this dilemma of getting to diagnose either it's a PSA or it's like a seronegative RA. And if the patient is having this like tiny lesions that are still seen by their dermatologist as eczema, would it be like politically correct to ask them for a biopsy, or what is the how to solve this problem? Thank you.
Yeah, so I think that if there's really the question, if your skin diagnosis is key to the diagnosis of the arthritis and you don't have any other means to diagnose it, I think you should do a biopsy.
So as a follow-up, Dr. Miriam, I have a question. When it comes, you have a patient with psoriasis, and what governs the selection of the biologics if the patient is a biologic patient? Because we, as rheumatologists in this part of the world, we don't get a lot of referral from dermatologists. So, for example, a patient with psoriasis might be put on an IL-17, but at the same time, he or she might have an IBD. On the other hand, a patient might be prescribed an IL-23, while the patient has sacroiliitis, for example. So what governs the selection of the biologics in the dermatology world? Thank you very much.
So in many situations, we have considerations for how expensive a biologic is. So within some hospitals, we have the internal rule to start on a biosimilar first. And then if this is not successful enough to move on, we would normally take into consideration inflammatory bowel disease and contraindication, as Louis just has mentioned. So that would be the dermatologist taking this into consideration. Then there is the other idea that shared by many dermatologists that we probably should start with the best treatment we have available. And the idea is that this could impact on the tissue memory. So if you get clear, almost clear for a long enough time, let's say half a year, that may increase your chance to have sustained improvement of your skin condition. This remains to be proven, but there is some idea that if you really go in with the best available one, that may have some influence on the disease course.
Louis?
Yeah, I would like to make one comment regarding the suitability of taking a biopsy specimen for the purpose of diagnosis. It is okay, but you should count on a seasoned or at least well-informed dermatopathologist, because in some locations, and I think about the flexures, the palms, the plants, so the presence of spongiosis does not rule out psoriasis, and and sometimes there are also mixed phenotypes that many patients might have atopic predisposition, and they might have eczema in some places, psoriasis in others. So this must be requires a lot of knowledge. And then regarding the choice of interleukin-17 antagonists for patients with a prior history of inflammatory bowel disease or even family history, so I would not recommend it generally, but we must remember this is not a contraindication. So the only thing, because eventually the risk of triggering or worsening psoriatic, inflammatory bowel disease is not so high. So perhaps it can be indicated, but then special concern, special follow-up should apply to those patients.
Can I ask you a question, Luis, about comorbidities?
Yes.
I mean, we're all busy people. We see lots of patients in a clinic, although in the combined clinic we see less. We've got the skin to look at, we've got the joints to look at, we've got the entheses, dactylitis, and spine, and so on. How on earth are we going to manage looking at for comorbidities as well? Do you have a special way of doing this? Do you let the GP do it, or do you have a scheme in your clinic?
I try to get the GP involved in doing it, but let's say the feasibility of control of the patient's comorbidities, especially the components of metabolic syndrome, by GPs is under par, even with patients who do not have psoriasis. So patients with psoriasis have a worse control of their comorbidities, and I might start, for instance, statins or some antidiabetics while I wait for the patient to get an appropriate referral. Of course, in hospitals, when you have, let's say, multi-specialty treatment of patients, we always, rheumatologists are our brothers in arms, but we also count on the support from hepatologists, gastroenterologists with an special interest in IBD, and also cardiologists. But it's not so easy. I would say that any dermatologist should be able to tell their patient that, okay, you have hypertension, but your hypertension is not adequately controlled. You should get a special change in treatment or whatever. And nurses, when available, and trained nurses can be most effective in providing this kind of, let's say, backup and follow-up.
Yeah, thank you for that. Dr. Walid, have we got some more questions from the floor?
No, the floor is yours now.
I'm aware that we're a little bit behind time here. There was just one question for Dr. Miriam about, let's see, we've got so many questions. Unfortunately, we can't take them all, but there was a question about earlier and more aggressive treatment of this disease. And you've already alluded to the fact that perhaps if you treat the skin more effectively, you're more likely to get prolonged remission. So I guess the other half of the question is, if you treat the joints aggressively, do you stop the progressive deterioration in joint health? And the answer to that question is we don't quite know. It's not quite the same as rheumatoid arthritis. There are hints that that is the case. And one of the hints is, of course, arthritis mutilans. If I were there with you in Dubai, I'd ask you to put your hands up if you'd seen a new case of arthritis mutilans in the last year. And I'm pretty sure none of you would put your hands up, because I think this is a disappearing aspect of psoriatic arthritis. And I think it's disappearing because we are treating earlier and with more aggressively, with more effective drugs.
Yeah, so just with regard to the tissue memory aspect. So this is more investigated in skin, where we know about this phenotype of tissue resident memory cells, and they have been found in psoriasis, and they can survive in the skin quite a while. And we think that they are contributing to flares and to disease, maintaining the disease activity. So it's something we can monitor more easily in skin, but we still don't have the full answer.
I would like to comment that circulating CD8 positive tissue resident memory cells have been found to be circulating in patients with psoriatic arthritis and not in patients with psoriasis. So that's
weird, yeah. Good. If you've no more from your end, Waleed, we should probably move on, because we're fully 15 minutes behind at the moment. So I'd like to thank Dr. Wittmann and Dr. Puig for their contribution to this discussion. And you are now free to go about your day while we finish the meeting. So thank you all for attending. I can see Kaveh has appeared, but we're a little bit behind Kaveh, so you'll have to listen to me talk a little bit about enthesitis. So we'll move now to the next presentation, which I will try and share with you. So thank you very much for that. I'm aware that we are behind time, and I don't like to keep you longer than you would like to be, given that this is your, as it were, day off. So there are some polling questions within this presentation I think we may skip in the interest of time, because they can be very time consuming. And I'll try and get through the presentation quickly, because I know that, as I say, we've got Dr. Shams waiting, and we do want to have some time for some more discussion at the end, and we do want to finish on time. So I'll talk about a little bit about dactylitis first, how we define it, how we assess it, tips for spotting it, and difficult cases. So dactylitis, it sounds straightforward. It's uniform swelling of a digit so that you can't distinguish the joints. But that's, having said that, it's good to spot it when it's obvious, but more difficult when it's not obvious. And you'll see here in the toes an obvious second dactylitic digit and the fourth in the bottom left. But on the top right, the hand is a little bit less certain, but it's the right index finger. And I would point out that in psoriatic arthritis, you can also get a sort of whole limb dactylitis. And here's a patient who had swelling of the whole limb and demonstrating the pitting edema that you can get. of these cases, one of the polls was which of these have got dactylitis, but people can usually spot the top left A, the top right B, which is the right index finger, the bottom right, again, the right index finger, but C, people often make the mistake of pointing out that it's the middle finger of the right hand. In fact, C doesn't have any dactylitis. They're a picture of my hands, but it just shows you that the subtle cases can be hard to distinguish. And particularly if there's extensive psoriasis, because that can cause soft subcutaneous edema, and the patient looks to have dactylitis. Obesity, of course, makes it very difficult, and there are other disorders that can cause dactylitis, of course. And here's a patient who was in the Ticopa study. They'd already been treated at this point, but when they first presented, it looked as though they had widespread dactylitis in the thumb, little finger, and so on. And of course, the other causes are TB. We see 1 or 2 cases of tuberculosis causing dactylitis. Sarcoidosis is not an infrequent cause, but of course, it's a less common disease. Gout can look like dactylitis, and of course, infections of the flexor tendon sheath. And also, I'd add to that list fractures, because a patient came to me with what clearly was a dactylitic toe, and I said, well, I know what's wrong with you. And he said, oh, by the way, doctor, does it matter I dropped something on my toe yesterday? So you can be deceived a little bit that way. In fact, dactylitis is more common in sarcoid, but we see a lot less sarcoid. So most cases we see in clinic are due to spondyloarthritis. And here's a case of gout where there's possibly, or probably is, dactylitis of the right index finger because of loss of definition between the joints. If you've got sarcoid, you get your dactylitis early, but it's more of a late feature in gout and psoriatic arthritis. And dactylitis resolves quickly in sarcoid, but is often unresponsive in gout and poorly responsive to NSAIDs and DMARDs in psoriatic arthritis, although biologics are effective. You will often see dactylitis in both hands and feet, more commonly in feet, I have to say. So unless you look at the feet, and as I've just said, there's a big disadvantage in the UK where people come in with multiple layers on their feet and don't really want to take their shoes and socks off. But it may be easier for you in Dubai because they come in thongs or whatever. In the hands, it's more common in the index and middle finger, and more in the right hand than the left. And in the feet, it's more common in the fourth toe than the others. And there are various reasons or hypotheses put forward to why some toes or fingers are more frequently affected than others. And trauma is one of the reasons. So we can reasonably reliably detect dactylitis, but not very well. And we showed that in our reliability study, in which we included various subtle cases. In this case, it was at the left fifth toe. But I think the fifth toe is a common problem in people trying to detect dactylitis, because it does look like a little sausage anyway, and you need the other side to compare. And you've seen this already, but this was a man in our reliability study with dactylitis of the right index finger, but it was missed quite often in that study. But generally, we agreed on which toe and finger had dactylitis. Dactylitis in a digit is a marker of severity, and you'll get more X-ray progression in that digit if you have dactylitis. And at presentation, if you've got dactylitis, it's usually a severity marker, so you'll have more tender and swollen joints, more enthesitis, and worse function if you have dactylitis. So what's the pathological basis? Is it synovitis, tenosynovitis, soft tissue inflammation, bone inflammation, enthesitis? One of the questions included all those, and the answer is it's all of the above. If you take an MRI scan of a dactylitic digit, everything's going on in there. It's like a paradigm of disease. Although historically people have favored one pathology over the other, the work that we've done, and here's an MRI image that we took of a dactylitic finger, it really shows everything going on. There's bone edema, there's synovitis, there's enthesitis, there's tenosynovitis. And I try and persuade drug companies to let me do new drug treatment trials on dactylitis, because the response that you'll see in the tissue is a paradigm of what's going on in the rest of the body. You wouldn't need to do these multi-million-pound, 1,000-patient trials if you could just do it on a few dactylitic digits. There's some more pictures. So we saw all these features in our dactylitic digits, as I've just labeled here. And in fact, you can get a sort of non-tender dactylitis, so-called cold dactylitis. And we showed in our study that the pathology of tender and non-tender dactylitis is exactly the same. There's just less of it going on in non-tender dactylitis. So how do we assess it? Well, in clinical trials, most trials just count the dactylitic digits, but as you'll probably understand from what I've said, because we can't reliably spot it, that is a very unreliable way of assessing it. And we've developed the Leeds dactylometer, which allows you to make a more reasoned judgment as to which digits are swollen. This is now being used in clinical trials. And, you know, the scores can be quite reasonable. And this was a case who had a score of 28.4. They had one middle finger involved. I injected the middle finger, and a week later, the score had dropped dramatically. And if you've got two digits, it all adds up. So this patient had a score of 96.1. The question is, where do you inject the steroid, of course? And I'm often asked this question: do you put it in the joint, the flexor tendon sheath, the enthesis, or all of those? Well, it's pretty difficult to inject little minor capsular entheses in the fingers and toes. So generally speaking, what I do is both the joint and the flexor tendon sheath. And the joint, I'll usually put it in the MCP joint, but also PIP if it's involved. What do Grappa recommend for treating dactylitis? Well, in the gray there, you'll see that there is a progression from NSAIDs to biologics and switch biologics with steroid injections as indicated. And more or less all the biologics have shown efficacy, which includes TNF, 1223, 1723, JAK inhibitors, and Premolast. And more recently, the SEAM PSA study has given us more firm evidence that methotrexate also can help cases of dactylitis. Dactylitis is an important clinical feature. It's a giveaway diagnostic marker in spondyloarthritis. It's a severity marker, and it's poorly responsive to conventional treatments, but generally well responsive to biologics. And moving quickly on to enthesitis, it's an important hallmark of disease, and we know that from the talk we had yesterday from Kurt de Vlaam, where he postulated that enthesitis is the primary lesion of spondyloarthritis. And assessing it, there are a number of indices, but what's used most common in clinical trials are the SPARC index, which assesses 18 sites, upper and lower limb, and the leads. Where's my leads? I seem to have lost my leads, which is 6 sites around the elbow, the knee, and the Achilles insertion. Enthesitis is pretty commonly present. It's about 50 to 60% of our patients have it. And I teach my dermatology colleagues, don't worry about all the other sites, just look at the Achilles insertion, because that's the most reliable major enthesis of the body. The problem with the rest of the body and the enthesial sites is that I suspect that clinical enthesitis doesn't purely represent pathological enthesitis, and we know that from ultrasound. So that pressing enthesial sites around the body is perhaps more an assessment of allodynia, of pain sensitivity, than it is of true enthesitis. And I think we must be aware of that when we see these clinical trials from companies saying, and their enthesitis score dropped by so-and-so or disappeared. I think what's happening here is that you're controlling their general centralized pain sensitivity more than their pathological enthesitis. And what we need are clinical trials using ultrasound as an outcome. And the Grappa guidelines now recommend really a similar range of biologics and oral TSD-MARDs to dactylitis, as well as the corticosteroid injections. And which can you safely inject? Well, virtually all of them apart from the Achilles insertion. You do not want to be sticking a needle at that point or anywhere near it because of the chance of rupture. So if you want to inject around the region of the Achilles insertion, you should be injecting the retrocalcaneal bursa in front of the Achilles tendon. And that suffuses, as you can see in the MRI picture here, the Achilles insertion area. This is what happened to, not a case of mine, I have to say, but someone who had had their Achilles insertion injected with steroids. It ruptured and ended up with a big screw at the point of insertion. You don't want that to happen. It doesn't matter if it happens at the lateral epicondyle of the elbow, it usually cures the enthesitis, and same with the plantar fascia really, but it does matter at the Achilles and actually around the knee at the patella and quadriceps tendon insertion. Do not be injecting there either. So enthesitis and dactylitis are giveaway features, as I say, and treatment may be a challenge, although nowadays the biologics and the targeted synthetic DMARDs we're finding effective treatments for these manifestations. So I think that we have that backup if conventional treatments don't work. So if you've any questions, we'll come back to those later, but I'll let Dr. Waleed now introduce our final speaker, Dr. Kaveh Shams.
Okay, thank you very much, Philip. For a nice talk. It gives me great pleasure to introduce our today's last speaker, Ken Shamus, who is an associate clinical professor and honorary consultant dermatologist at the University of Leeds. He is the lead of the dermatology clinical trials unit and the principal investigator and chief investigator for a range of clinical trials across multiple disease areas. His research focuses mainly on inflammation of the skin disorders and particular leukocyte migration and stromal inflammation and cell interaction and their role in driving the skin disease. So without further ado, Dr. Shamus, the floor is yours.
You're muted, Kaveh.
I have just unmuted it. Can you hear me?
Yeah, we can hear you.
And I'm just making an attempt at sharing my screen, so just bear with me, please. My apologies. There we go. I think this should be us. So my apologies for the delay. So my talk will focus on quite a large subject area, which is our bread and butter in the psoriasis clinic, really, which is difficult to treat psoriasis. And as you will all already know, we live in a world where there is seemingly an almost exponential increase in the number of monoclonal antibodies that we use therapeutically. And it wasn't long ago that the FDA approved the 100th monoclonal antibody product. And it is very much true to say that the situation in terms of prognosis looks better than ever for many of our patients with inflammatory skin disorders. But the availability of such a large number of drugs is somewhat at odds with the lie of the land in terms of treatment needs. What I'm hoping to do today is to focus on two aspects, or two sort of challenging situations. We're going to start off with an overview of the challenges which we face as clinicians in the dermatology clinic, but we will also more specifically delve into scenarios where the patient has experienced multiple drug failures, and the concept of immunogenicity, which our rheumatology colleagues are probably more familiar with and have more experience with than us dermatologists, but it's still a relatively new entity. Secondly, we will look at psoriasis associated with comorbidities and special site involvement, which is another clinically challenging area in which to operate as a clinician. Now, these are data from the UPLIFT study that I have been involved with, where we collected data from 4,000 patients with psoriasis and psoriatic arthritis across the world, and 1,000 dermatologists and 1,000 rheumatologists to better understand the current treatment needs and deficiencies and treatment perceptions amongst clinicians and patients. The UPLIFT study is a follow-up to the so-called MAP study depicted on the right. And what I would like to draw your attention to here, on the left in UPLIFT, is that the majority of patients, more than 50% of patients with psoriasis of any degree of severity, appear to be either on no medication or on topical agents alone. So quite a stark contrast to the sheer volume and number of drugs that are currently available. At the same time, our preliminary UPLIFT data suggest that our patients with psoriasis and indeed also PSA are at very high risk of depression. And that's whether we look at outcome measures such as the PHQ questionnaire or DLQI. So these are not trivial conditions, and this is pooled data for all degrees of severity. And there are lots of barriers in the way of our patients going from no control on the left to good psoriasis control on the right that we as clinicians do need to be aware of. So recent UK data suggests that there was a 15-year median delay in a patient with severe psoriasis being seen by a dermatologist. And this depends on a multitude of factors. Our national guidelines, reimbursement schemes and different perceptions between physicians and patients in terms of severity also a great hindrance in terms of achieving good disease control. And comorbidities is only now being properly addressed, I would say, in dermatology, and still we're to a large degree operating in the dark. We do not know, for instance, how biologics might alter outcome in terms of cardiovascular disease risk excess. And lastly, there is quite a lot of data now emerging, especially from the United States, about unconscious bias. So patients from ethnic minorities having greater difficulty accessing care. And as clinicians, we have a great opportunity to help patients jump over many of these hurdles on their path from no control to good control. And the first step is to be aware of what these barriers potentially are. So I think the cases we have here are a little bit possibly jumbled in terms of number, but bear with me. This is our first case, despite the number at the top. This is a 71-year-old female patient of mine, history of intermittent and severe alcohol excess, liver function abnormalities. She does attend sometimes and not at other times, and have been a historical, a large number of compliance issues. Her plaque psoriasis is not insignificant, but it's also not extreme, with a PASI score of 6. significant palmoplantar psoriasis, and we've already looked at data, and there is data, indeed, that palmoplantar psoriasis has a disproportionate effect on quality of life compared to ordinary plaque psoriasis. Limited response to cyclosporin, limited response to Pruva. So what do we do next? So this is not for you to answer really, it's more of a rhetorical question. Where would we take her? Would we start an anti-TNF? Would we consider methotrexate? Would we consider apremilast? Though of course other options are available. And we'll circle back to this case after the next few slides. The first thing to say is that we often as clinicians look at PASI 90 response rates in phase 3 trials, and important as that might be, we need to remember that a 90% reduction of psoriasis can mean very different things. If you start off with a high PASI score at baseline, as on the right, 90% reduction still leaves quite a lot of psoriasis to be seen. Whereas if you start off with less severe psoriasis at baseline, PASI 90 could indeed be clinically meaningful. There is also a wealth of data of how poorly PASI and DLQI scores correlate, and all of you, I'm sure, will have had patients with trivial amounts of psoriasis in terms of PASI scores, but a sky-high DLQI. And patients such as the one I presented with a PASI score of 6 can be very difficult to manage because they don't reach certain thresholds to be eligible for systemics. So the cutoff in the UK, for instance, is PASI 10 for biologics. Also, it is very difficult to define what a moderate patient is, and it's lots of data now show that whether it is mild, moderate, or severe, it can have a profound and significant impact in terms of quality of life on patients, and that moderate patients are probably both neglected and also very challenging to treat. But there is still no true international agreement to what moderate psoriasis is, although this is an area that is quite active and is hopefully going to be rectified. It is also interesting that patients, that about 2/3 of patients with very little psoriasis, less than 3% body surface area cover, still consider their psoriasis to be severe, when most of us as clinicians probably would consider their psoriasis to be mild. This is further data from the Uplift survey I presented earlier, and special site involvement in plaque psoriasis is, I must say, more common than I would have thought. So more than 80% of patients have special site involvement in more than one area. And these are difficult to treat areas: so scalp, face, nails, palm soles, and genital skin. And special site involvement can happen even, as this plot shows, can happen even if the disease elsewhere is relatively trivial. But perhaps most importantly, these special sites have a disproportionate impact on the quality of life of patients. So as I briefly mentioned, palmoplantar psoriasis leads to greater quality of life impairment, looking at both DLQI scores and EQ5D scores compared to plaque psoriasis alone. So these are not trivial matters. And when we ask patients what matters to them in terms of what a drug should do, effectiveness as precisely these special sites, including scalp, genital skin, and palmoplantar skin, is one of the most important factors to patients. So this is not a side issue for patients we see in clinic. And what they expect from us as clinicians differs depending on which site is involved, which I think is very interesting. So a patient with genital psoriasis would expect their treatment to work a great deal faster than somebody with, for instance, psoriasis affecting the nails or the scalp. So what did we do with this patient of ours? So PASI not sky high, but does profoundly affect her quality of life. Compliance is a little bit erratic. There is this history of compliance issues, attendance problems, monitoring problems. So what did we do? So in her case, we elected to go for apremilast. My feeling was that she would not comply with monitoring requirements for either adalimumab or methotrexate. I had concerns about alcohol overall intake in terms of methotrexate, and sort of subgroup analyses from a Premolast studies for palmophantar disease is relatively favorable. And this is her at baseline on the left, and this is her 4 months after Premolast was initiated. So remember that diseases can have different effects on the patient depending on the site. The second scenario that does happen very often and sometimes repeatedly and can be a bit of a heart sink as a clinician is the scenario where we have multiple drug failures and the concept of immunogenicity to drugs. So this is a 63-year-old patient with severe psoriatic arthritis, but also skin disease. She has had secondary failure to adalimumab, secukinumab, and most recently ixekizumab. So PASI again, not dramatically high, but significant and affecting the patient's quality of life. So here we elected to start the P19 IL-23 inhibitor risankizumab, which we have had very good experience with. She achieved in terms of skin PASI 0 after one single injection, but it was clear that she needed a bit of more specific IL-17 blockade because her PSA flared very dramatically, reducing her mobility very quickly. Gradually, though, she developed again secondary failure to risankizumab in terms of her skin response with a PASI of 4, which was mainly flexural. So we have PSA on one hand and skin disease that is gradually worsening. So what do we do with her? Do we go for the IL-17 receptor blocker, brodalumab, another P19 inhibitor, guselkumab, or go back to another anti-TNF, certolizumab? So again, we'll get back to this case. It is worth reminding ourselves that we are dealing with a natural product in effect. So monoclonal antibodies are engineered, and there are three main classes of them. So some are chimeric, like infliximab, which is a large proportion mouse, and some human parts as well. Many antibodies are humanized, so they often start life as a chimeric antibody that is then reverse engineered almost to become more human. An example of this would be ixekizumab. So anything ending with a zumab tends to be humanized. And fully human antibodies such as secukinumab, adalimumab, which at least in theory should look identical to the human situation, although there are subtle differences. And immunogenicity is driven by many factors. So some of them do indeed depend on patients. So patients who are older tend to develop antibodies less generally. But a lot of what makes something more or less immunogenic depends on the drug and the route of administration. So we've already talked about the structure of the monoclonal antibody, but intravenous infusion, for instance, tends to be less immunogenic than subcutaneous, and giving doses more frequently is often less immunogenic than giving it infrequently. And the rates of anti-drug antibody formation is very variable, as I've tried to summarize in this here. So we've said that adalimumab is a human monoclonal antibodies, but the anti-drug antibody levels, ADA, is about half of the patients receiving it. Infliximab predictably fairly high, but even within a class, you can see big differences between different antibodies. So look, for instance, at risankizumab and guselkumab of 24% and 8.5%, and similar differences between the IL-17s with anti-drug antibodies to the humanized ixekizumab being higher than the human secukinumab, for instance. So what is the consequence of this? So why should we pay any note to this? It's because you can have neutralizing antibodies depicted on the left, which as the name suggests, neutralize your drug. So as you're infusing it or injecting it, the immune system is mopping it up. We can also develop more side effects due to aggregation, for instance, and this is what we often see with infliximab, for instance. But the point to also make here is that when you look at papers and there is a lot of focus and emphasis on neutralizing antibodies, remember that the non-neutralizing antibodies can also affect drug availability to, for instance, affecting pharmacokinetics, so how the antibody moves and is cleared through the body. So does this all matter? Does it matter in the real world? And it does seem to be that it does. So this is one of many papers in the Chinese population showing that the presence of anti-drug antibodies to adalimumab predicts a less good clinical outcome, and for instance, not using concurrent methotrexate increases the risk of anti-drug antibody formation. But what do we do with this in practical terms? Be aware of it. It probably explains a great number of our secondary failures. And there is this quite recent working group here having published some advice on how to categorize different biologics depending on likely immunogenicity. So group 1 would be high likelihood of anti-drug antibodies that might lead to failure, so adalimumab and infliximab. Group 2 would be high likelihood, but not quite as high. So here we have ixekizumab and risankizumab, and group 3, where the risk of anti-drug antibody formation is very low. So brodalumab, guselkumab, and secukinumab. So this patient of ours has failed this drug. Would there have been enough time to develop anti-drug antibodies to risankizumab in this short period of time to account for this failure? I am not certain, but we have 2 conditions we need to treat. So in her, sorry, the arrow has moved a little in me transferring it across, but we actually elected brodalumab for this particular patient. So what we do tend to do in the dermatology clinic here, we make a difference between primary and secondary failure, where a patient has experienced primary failure, so you get no effect from a drug as intended, as you started. We tend to switch out of class. So switching her to guselkumab would have been, in my view, less logical. If you get secondary failure, which is what she had experienced with other IL-17 blockers, it makes more sense to switch within class. So we moved on to brodalumab, which is not licensed for PSA in the UK, but the phase 3 clinical trial data is very compelling. So to summarize my section, we have discussed the concept of multiple drug failures and immunogenicity. Bear in mind that anti-drug antibody levels vary greatly depending on the drug. Switch out of class if there is primary failure, try to stick within class if there is secondary failure. Comorbidities, secondly, they are not trivial, and special site involvement can have a much more profound impact on the quality of life of patients than you would expect. And remember that there are numerous barriers in the way of our patients going from poorly controlled psoriasis to clear psoriasis. And many of these, although we have only brushed past them today, are amenable to your control as a clinician. So we can help them overcome things like poor access due to unconscious bias, for instance, and help them come to terms with their disease more quickly. So I'm happy to take any questions there might be.
Okay,
Here I am.
so I have a question here regarding immunogenicity issues. There was time in which conventional synthetic DMARDs like infliximab, adalimumab, however, recent recommendations stated that they need not to be used together with the biologics. Basically, with the newer biologics, not the anti-TNFs, do we need the conventional synthetic DMARDs? And if no, why not?
In my view, no. I think there is a slight discrepancy between the clinical data that is available for phase 3 studies and now emerging real-world evidence and the emergence of neutralizing drug antibodies. So for instance, I mentioned that risankizumab we commonly see anti-drug antibodies, but the reality is that the sort of 3, 4, 5-year data that is emerging looks very positive. And a loss of response is less likely, but as my case illustrates, not impossible. It can happen. The data also on the utility of DMARDs alongside biologics is also a little bit conflicted, especially in dermatology, probably more so than in rheumatology. Some papers suggest it's helpful, others that it isn't. I haven't seen a compelling case for starting, for instance, methotrexate along anything else but infliximab. So I don't tend to. But it's just a concept that we need to be aware of, that it might happen, it might become a problem, and have a strategy for overcoming it. And that could, for instance, be increasing the dose. And for instance, secukinumab will be available as a 2-weekly injection soon. And that is one way of overcoming any anti-drug antibodies that might emerge, for instance.
Is Luis, are you still there? There's a question here, Kaveh, from earlier.
Yes, I am. Yes,
oh,
I am.
Good. Well, the question that was directed to dermatologists in general, but I was going to ask you and Kaveh. There's a question here. It says, why do we use systemic steroids in erythrodermic psoriasis and pustular psoriasis, and not in psoriasis vulgaris?
May I answer first? So we are using them in very severe diseases, mostly because they work. The problem is that with long-standing use, they tend to lose response. We tend to incur insignificant problems regarding the catabolic effects of corticosteroids. And when lowering the doses, perhaps after some time, there might be relapses and rebounds, which might be pustular. Not so frequent. They seem to be more dreaded upon than real, according to some recent publications, especially from German colleagues. But these are the main problem is these rebounds or pustular relapses. Now, we have very effective treatments nowadays. Infliximab was the first one which became widely available, and it has been shown to supersede in our practice the response to corticosteroids. We have been favoring cyclosporine for a long time, also for those bouts of erythrodermic and pustular psoriasis. But when they fail, infliximab, eventually perhaps anti-IL-17 blockers, brodalumab, or perhaps the newer IL-36 antagonists which are under development might provide a better and more targeted or specific alternatives.
Thank you.
And if I may just add to that as well, Philip, that I think that the conventional wisdom has often been that if you have plaque psoriasis and you use systemic steroids, you might destabilize them and push them towards erythrodermic and pustular phenotype. And we do see this sometimes with GPs using high-dose prednisolone when they don't know what they're dealing with. And I guess the thinking is that if somebody has erythrodermic and pustular psoriasis already, the cat is out of the bag, as it were, has happened. So the worst case scenario has already happened. So you can only improve from there. But I would agree that IL-36 blockers look very promising for GBP. And also acitretin, if I may add that. We've had a lot of good experience with acitretin, which is a bit counterintuitive because it's not our most potent and successful treatment, but it does work quite well.
Yeah,
very slow anyway.
Slow, yeah.
I recently had a patient with psoriatic arthritis, one of mine, who developed polymyalgia rheumatica. So I had to give him 15 milligrams of prednisolone, not a big dose, which he had for about 6 weeks and then began to taper. And the next visit he came, his psoriasis was much worse. It wasn't erythrodermic, but it was pretty bad. And there I am thinking, here I am an expert, and here I am giving someone worsening disease. But, you know, sometimes you just have to use steroids, and you have to be aware of the consequences, I think.
Yeah. Absolutely. And you see it sometimes with topicals, very trivial quantities of topicals to very select areas. I've seen it happen once or twice where it just spreads like wildfire.
I would like to comment that subcutaneous or intraarticular or intramuscular injections of corticosteroids are really associated with these flares that take place approximately 7 days to 2 weeks after the injection. So rheumatologists should be quite aware and concerned of this potential complication.
Yeah.
Because you're injecting like 40 milligrams, which is not, let's say, a negligible dose.
Yeah. And Waleed, were there any questions from the floor in Dubai?
Well, there is a question. When it comes to choosing the biologics, there is sometimes a disconnect between the skin and the joint. They're not aligned. So if you were to choose between the joint and the skin, the question is for the dermatologist and one for the dermatologist, the panel. Which one would you, which drug would you choose to try to hit both if possible?
If I can answer first, I would like to, in my view, the pain is always worse than itch or more or less pain that can occur in the skin. So generally, the musculoskeletal manifestations take the lead. Then in many cases, anti-TNF-alpha agents can be helpful for both of them. But in patients with more severe skin disease, when you want to get a faster and more profound effect on the skin, I would recommend IL-17 antagonists. They can provide the best of both worlds in that respect. If you are using ustekinumab or guselkumab or some of the risankizumab, any of the P23 antagonists, it might occur that the articular manifestations improve, but in some cases we can see some flares or some appearance of some arthritis. So I would say this can be used and they can be helpful, but for in this balance there's a similar arthritis and psoriasis, I would go for an IL-17 if the anti-TNF-alpha, which is cheaper in our practice, fails.
Yeah, and I think just to add to that as well is that I think that this question just highlights the importance of us working closely together, because often that is the rank order, but we don't need to choose. We can have both, and by working together closely, you can usually achieve control of both.
I would like to put an example. If in one patient with a prior history of inflammatory bowel disease, for instance, you might the arthritis might become severe. The patient is an anti-TNF-alpha agent, adalimumab. Working together with the rheumatologist might allow you to use, for instance, golimumab, which might be a solution for that patient.
Yeah, and I think it's important that we all know that we're dealing with one disease. So when I look at patients, I have to look at the skin in order to decide which treatment to use. And from your point of view, you have to be aware of the joints, and the pain, as you say, is an important factor in that manifestation. So if we can't work in the same clinic, at least we can recognize each other's specialty. I'm aware that it's now 1:15 my time, which is the meeting closed. Waleed, have you got any burning comments or questions from your end?
No, nothing from the floor, no, not from the. So I think the speakers have done a great job answering most of the questions.
Thank you very much. Yes, so shall we close the meeting, Waleed? Thank you very much, Luis and Kaveh, for your contribution. And thank you to all the speakers who've gone before. And thank you also to Dr. Waleed in Dubai for chairing the meeting live, as it were. And of course, we thank Novartis for their support. But I'll leave the last words to you, Waleed, to say goodbye.
So I think thank everybody for this meeting. I thank the speakers for the excellent talks. I thank the organizers, Infomed, and also special thanks to Novartis for supporting this meeting. We hope that hopefully by next year, this meeting will be face-to-face by September next year, and we'll have everybody here, like we have some of the people here. So we will not have any more virtual next year. Thank everybody, and hoping them to stay safe, healthy, and prosperous. Thank you very much.
Thank you. Inshallah.
Thank you. Bye now. Thank you.